program going on there. I put it there. I want to know chart.
Charge.
So from our side, we are muting everyone because it's only 30 seconds to go. Good evening to all of you. It's a pleasure and honor to welcome you all to this virtual conference on coronary interventions in collaboration with EAPCI, which spans over the next 3 days from 6:30 to 10 p.m. in the night. The organizing team has started out a fabulous program ranging across different complex case scenarios, including primary percutaneous intervention, bifurcations, calcifications, tips and tricks to avoid complications, and how imaging can be effectively used in handling complications. To take us through these sections, we have 7 international faculty and 54 experts of national repute delivering the best from their experience, and we have 6 live cases bar case in the box to give an immense learning experience. Ample time for discussing each topic would be the highlight of this webinar. With this short introduction, let me take this opportunity to welcome and introduce the expert panel as well as the moderators. Regarding the expert panel, we have Dr. M.G. Pillai, who is joining us from Mumbai. He is the senior most interventional cardiologist who works at Leelavati Hospital in Mumbai. We have Dr. Louis Fisher. He is a chief interventional cardiologist and professor at MOSC Medical College, Kolanjeri. We also have Dr. Shafiq Matumal, who is the senior interventional cardiologist at Aster MIMS, Calicut. And we also have Dr. Sampath Kumar, who is a senior interventional cardiologist at Meenakshi Medical Mission, Madurai. Now, to moderate the session, we have two very eminent faculties over here. We have Dr. B.C. Srinivas, who is a professor and head of the department of Jayadeva Hospital in Bangalore, and we all know about his interventional skills. He hardly takes 10 minutes to do a balloon mitral valvuloplasty. And we also have Matthew Samuel, sir, with us. He doesn't need any introduction to this audience. He's the father of interventional cardiology. Sir, kindly take over the proceedings. And the first case would be from Amrita Hospital, headed by Dr. T. Rajesh, who is the head of the Department of Cardiology, with Dr. K.U. Nadarajan, who is a professor in the Department of Cardiology, and with Dr. Rajiv C., who is the clinical professor at Amrita Hospital. Kindly take over, sir.
Thank you, Deepak, for the interesting introduction, and I know you have managed to get a very interesting faculty from all over the country, and with them in the background, who's going to contribute tremendously to the whole discussion. I will not stop in between the next presentation, which is from Amrita, especially Dr. Natarajan. I have had a chance to work with most of these people, and I'm thrilled to be moderating the session today. And I can see Pillai, we actually worked together for the first angioplasty case in Bombay. It was his patient whom we started the whole interventional cardiology for this country. And I'm glad to be with all of you. And let us go to Amrita and listen to the presentation from Natarajan and his team. Rajiv or Natarajan, who is presenting, please go ahead.
Rajiv.
Good evening, everybody. Sampath Kumar, all known faces. And very, very pleased to be with you all.
Jim, you can take over.
Yeah. Good evening, respected senior cardiologist.
You are not audible, Rajiv. Can you make it louder?
I am audible. So we have. Am I audible?
A little better. Can you make it better?
If you can hold the microphone to your face.
Okay, go ahead, Rajiv.
Sir, you can share your laptop, sir.
The screen visible?
No, yes, not slides are not visible, sir.
Sorry. Just a second.
See, there are two rows of switches there. The first, the second, and third. Can you put it on?
Welcome you all to
Am I visible
the
now?
Amrita Institute
No, sir.
Cath
No,
Lab.
sir. Only desktop is visible, sir.
We are going to
Sir, video is not coming.
Yes, yes. Share.
Sir, go to share screen, and in that share screen, yeah.
Now?
Okay, sir.
welcome you all to the Amrita Institute Cath
Okay,
Lab.
now?
We are going to
Is it okay now?
do a case with some calcium.
Yes, sir.
I am Dr. Rajiv. I have my close friend and colleague, Dr. Natarajan, along with me. So we have our scrub nurse, Sri Kuti, then Cath Lab techs Sri Lakshmi, then Neetu, and we have nursing chief Rose Sophie with us. And we also have a anesthetic backup. And we have Mr. Santosh, who is going to help us with the OCT. So it's a brief introduction about the case. This is a 71-year-old gentleman who has diabetes and hypertension. He had come with class 2 angina. His treatment was positive. And this was the angiogram that we did. Stop. Yeah. So this is the angiogram. So we have separate origins of the left and left antedescending artery and left circumflex. We don't have a left main. It's a little difficult to hook this. We have to use 7F3 guiding EBU guiding catheter to engage this LAD. So LAD has this is just beyond the proximal segment. Can you go to the next view, please? And we have significant calcification of the proximal LAD. Next, please. And the proximal LAD is very calcified. You have a 95% eccentric stenosis. And we have a diagonal, 2 millimeter diagonal arising just beyond the major lesion. Its origin seems to be quite free from disease. And beyond the first diagonal, we have another 80% disease of the LAD. And this LAD is pretty all right.
Yes, sir.
So,
Yes, sir. Magistrate?
Can I interrupt you at this?
Please.
Rajiv, now you said you have an independent origin of the LAD and circ.
Yeah.
It may be worthwhile discussing the cannulation of these coronaries because it's technically a very challenging situation to cannulate an LAD with an independent origin.
Yes.
Salient points, if you can mention it, will be very useful for people.
Generally, we have to reduce the curve. If you're using a 3.5, you can come down to 3. And EBU will be better. You can bring it up and clockwise rotate. And maybe let it push down to the sinus and make it look up. Generally, I think a reduction in the curve will work. So I would like sir's opinion or suggestions on this.
No, absolutely. It's very, very important. And using an EBU, which is less traumatic than many other catheters, would be definitely useful. And we have to selectively cannulate the ostium of the LAD. So you have to be very careful about cannulating that because it can cause injury to the ostium of the LAD itself. So be very gentle. And what we have done is, over the years, what we have done is having a coronary wire and also a balloon in the guiding catheter and wire the vessel prior to deep throating or cannulating and use that balloon or the wire to engage the guiding would be a useful technique which would be less injurious to the ostium of the LAD.
Totally agree.
Matthew, that means it's a floating catheter somewhere around the ostium, and then in a wire carefully, and then take a balloon,
Yeah.
and then slowly advance.
Then try to cannulate. That would make the whole procedure much safer. And
That's right.
our anxiety also will be less.
And you
Would
cannot
would you change the catheter into a smaller size, 0.5 less?
Rajiv already mentioned that instead of a 3.5 EBU, he took a 3 EBU downside so that he could engage it better.
Yeah.
Go ahead, Rajiv, please go ahead.
We have to strategize how to go about this case. Our initial plan is to wire it with a BMW wire, then do an OCT. If the OCT catheter is difficult to track through, we might take a 2 millimeter balloon to make way for it. Then based on the OCT, we'll go ahead and decide what to do. Yeah, there's some wedging. I will just cross the lesion and then relax the guide a little bit. Half CC check, please. We'll make an angio here. Pressures are now okay.
Why angio?
Let us see. There was no flow initially. Okay,
So
we'll need a balloon.
We need a pre-dilatation.
Please.
Yeah, we'll take a 2 millimeter balloon. 215, please. 215 NC. Even though the flow has reduced, the ECG is okay. There's no change in blood pressure. Dilate, please.
I think this is the diagonal.
Okay, gentle check. I'll remove the balloon. Yeah. We're dilating the second lesion.
Right. That should be fine.
Yes.
Can we make this a
We'll go OCT.
Okay, please.
So we'll do a OCT run now to understand the morphology, the length and the dimension characteristics of this vessel before we proceed forward. Okay, right. Take out the series.
Recording in progress.
I'll do it.
Ready for the OCT? Yeah,
Very good.
In this situation, you manage to dilate the lesion with a balloon and then try to do OCT. But if the
it's a very good injection, I think.
if the lesion were to be very tough, would you have done a rota first and then done the OCT run?
Yeah, definitely. If balloon is not going, I think that means we'll need a rota.
So we'll start from distal.
So this is an OCT pullback pre-PCI from LAD, and while we get the OCT pullback, you can see the fibrous plaque right from starting from the distal LAD, and predominantly a fiber plaque, unable to see the 3-layer lamina.
A small dissection.
Come back inside, you can see the dissection induced by
That's
the
the site
balloon.
of the distal lesion, I think. Yeah. That's where the distal lesion was.
This is a branch.
It's the diagonal.
That's a
Diagonal
diagonal branch
branch
with a normal ostium.
Lumen.
And as we come back,
Here you can see some kind of
Hypocalcific.
fibrotic plaque as well as
Calcium.
some
Yes.
calcium.
Deeper
Now
calcium.
starting
Deeper
to-
calcium.
deep calcium. Yeah.
It's more of mid-dimensional calcium, right from 7 o'clock up to 11 o'clock.
Can you go to the tightest point? Just come back a little bit. That's a proximal.
What is your comment on the proximal LAD, Santosh?
1 minute, sir. Yeah.
There is a lot of
So proximal LED, we can see some calcium, but it is not so deep. But some kind of calcium distribution is there, especially from a kind of mediate or adventure
6
calcium,
to
especially from 7 o'clock up to 12 o'clock.
2 o'clock.
That part doesn't warrant any kind of what you call atherectomy intervention. But if you come further down, you can see the calcium very clearly.
It's again more of adventitial.
Yeah, see. And this is more of a lipid pole. You can see here the attenuation is very high, and it's more of a lipid plaque. Now we are coming into the
That's the left
That's
main.
the ostium of the LED.
That is
yes.
the osteometry because there is no left main here.
Okay.
What is the additional information
Hepatitis point.
you got from the OCT on this particular patient?
No, so we knew that it's not, calcium is not really projecting into the lumen. So rotablation may not be needed or useful in this situation. It's more towards the adventitia.
So your choice would be a balloon or would be a cutting balloon in certain areas where you are seeing.
We discussed that and took a cutting balloon.
Around 35.
The tightest point is predominantly fibrotic plaque, sir.
No, further,
not that.
further proximal.
Further proximal as you go within 30 and
Between
40.
30 and 40. Yeah, be there. Be
There,
there.
there, that's the.
Yeah.
What's comment here? Yeah. Focus.
It's also predominantly fibrotic plaque.
Fibrotic plaque. It's not.
Is there any deeper
See,
calcium?
homogeneous and very bright pixels, quite representative of thick fibrotic plaque. And dissection induced by the balloon. And you can see some kind of calcium islands in between,
But that's very deep.
very deep. See, now you can
but
see the
there-
clear calcium coming out. And if you look at the lumen area at that point also, it's 2.34. And the calcium is predominantly from this area, that is from at least 7 to 9, and from the 10 to 11 to 12 o'clock position.
So since it is deep calcium, I think there is no much role for
Rotablation.
rotablation.
Yeah, intima is flea.
Whether we have
Completely
to go with a balloon or a cutting balloon, that's the question.
Exactly. So this kind of calcium distribution, rota won't yield anything, sir.
Yeah, yeah.
Okay, can you now go to dimensions? Can you go to the distal reference diameter?
Yeah.
Yeah.
So
What is it here?
as per the algorithm, we go to the distal to see the 3-layer lamina. So you move the cursor in such a way that where you can appreciate the 3-layer lamina. So here you
Yeah,
can
here you can see.
make out the 3-layer media to media. So you draw 2 points from the EL to the EL,
Yeah.
that is outer border to outer border.
78.
They come to 2.8.
yeah.
So, and also if you look at the lumen diameter, the mean diameter is 2.2 and EL to EL is 2.8. So it should be a 2.5
0.7.
distal.
Yeah, proximal LED, how big is the proximal LED?
So proximal LED, let us look at an area where the plaque burden is less, minimal lipid, and relatively you get a good lumen. So this is the area where you get a good lumen.
Yeah, yeah, you'll check there.
So let us take the measurement here.
Point 89.
So if you go by the
3.7,
EL to EL criteria, this should be a 3.5 at the proximal,
2.5.
and 2.5 at the distal.
Yeah.
And now comes to the length part. Length part, again you move the cursor, these 2 points, and here it is showing lesion to lesion healthy segment is 45.6. So you
take a
move
48.
in such a way that to the nearest stent length we will take. So better we will take further distal and take it to 48, sir. What's your opinion?
Absolutely.
No?
Now it is
Stent.
From where is the proximal extent of the measurement?
proximal extent here up to
So
the
here the
just
catheter is selectively into the LED.
yeah,
There is no left main here. So
exactly.
you have to be as close to the catheter as possible for
Yeah.
the proximal end of the
Yeah,
lesion.
just start
Okay.
from
Yeah,
the ostium. We'll start from the ostium.
Ostium, then you move it still here towards the where we have marked earlier. So that exactly makes you a 48
48.
length.
So
Yeah, I think
distally 2.5, proximally 3.5, 48 millimeter stent.
Length.
So what a 2.5? What is the maximum diameter to which you can expand it?
3.5.
It's 3.2.
Ideally 3.5.
If you go by the science.
Yes.
Yeah.
Can
0.5.
it be blown to 3.5? Can
Yes,
we do that?
yes. Even 2.75 can be blown to 3.5 with a 3.5 NC balloon, and distal
But
maybe.
here distally it's 2.5.
Distally it is 2.5, but then I think still we can use it 2.75 and don't postulate too much.
That's correct. We'll deploy a 2.75 into 48 at nominal pressures and work at higher pressures with higher size balloons as we come proximally. Yeah.
And using the need to debulk the main lesion, that is the thing that we have to address right now. So the question is high pressure balloon, NC balloon versus
Can one of you talk to the
cutting
patient?
balloon.
Cutting
Can you just
balloon.
go to the tightest lesion once again, make a decision on a cutting balloon versus
Before
high
we
pressure
stent,
balloon?
what further preparation is required is the
Cut and make it even better. That is the cutting balloon.
We'll take a cutting balloon.
I think we'll take a three cutting balloon. What's the diameter
Shave
there?
of the entire.
What was the diameter in which there was maximal deeper calcium?
Yeah.
What we can do is we'll take a 2.5 cutting balloon and then upsize a non-compliant balloon to match the vessel size.
Exactly.
So this is a 2.5 into 10 millimeter flex dome. Yeah.
Dr. Rajiv, for the benefit of beginners in the audience, so how do we re-stratify the calcific lesions, and how do we decide the different the techniques to prepare the lesion?
Yeah.
For the benefit of beginners.
Suppose there's significant calcium coming into the lumen intimal, which is preventing balloon going. I think it's rotablation. And sometimes even after rotablation, there's a lot of circumferential calcium. So an additional intravascular lithotripsy might be useful. Or in case where there's a lot of concentric calcification, but a balloon will be allowed, then I think direct IVL may be useful.
Yeah, so if they are uncrossable lesions, I think probably primarily we have to do a atherectomy, rotational atherectomy, and then you try to. But yeah, in this case, another interesting scenario was you pre-dilated with a balloon and then you imaged.
Yeah.
Now, if you had an intimal calcium, what would have been your approach? Whether it would have changed? Now we know that the imaging
if it
actually
is significant intimal calcium with such tight stenosis, it's very unlikely that balloon will go easily. Then we might have to start with rota. In fact, I was under the impression that we might need a rota. But the balloon surprisingly opened up without much difficulty. So then I knew that there's not much of projecting into the lumen.
Dr. Matthew, in this scenario of the wire crossed but the flow was impaired, and then if the balloon doesn't go, and if we do a rotational atherectomy, what are the chances of no flow? Do you anticipate in this case, in such scenario?
Chance of
No flow.
No flow.
see, if I got an additional information from this case, viewing it, because they pre-dilated with a balloon, which was not a balloon, a 2.5 millimeter balloon.
2 millimeter.
If you look at post-dilated pictures as well as the OCT findings,
Yes, it looks much bigger.
multiple levels of dissection.
Dissections have been created. Yeah.
So that means it's a very, very soft plaque. In such situations, if you use a rotablation, slow flow is definitely higher and it will not yield any either. So when you have soft lesions, it is better to stay away from
Atherectomy.
or even cutting balloon also, because we have multiple layers of dissection and having hematomas where the cutting balloon blades are the blades resect the intima. We have seen multiple levels of hematoma also. So I generally, if you find soft lesions like this, I would like to avoid. Even though the OCT picture gives us information that it is a very fibrotic lesion, fibrosis generally would have done well with the cutting balloon. But in this particular situation, I would be little careful with that.
We used cutting because it, basically a fibrotic lesion, and there is no thrombus. So we didn't see
I totally endorse your view.
And then we used a 2.5. Do you think it is smaller, or would you have used a 3?
Yeah, I think 3 would be too big. 2.75
would be the right
available.
choice.
If it is not available, 2.5 is the.
Yeah, that's what happened. I wanted a 3, but then the distal lesion is also fibrotic, so we thought
3 will be too big. 3 will be too big. You will have more problems with the cutting balloon than.
For the Rajiv, for the benefit of beginners, the imaging actually showed very beautifully in this case. The calcium was actually distributed in less than 180-degree arc. Number one. Number two, it was deeper, closer to the adventitia rather than intima. If it is an intimal calcium, I think we had to resort to some sort of a atherectomy. If not, because you had pre-dilated, maybe lithotripsy would have been the choice here in this case. If we had to do a intimal calcium disruption, if we had to do, probably we would have chosen a post-dilatation. Probably would have chosen a lithotripsy as a way of treating the calcific lesion. Number one. Number two, because it is deeper calcium, we can still do away with a non-compliant balloon dilatation in most of these cases because it does disrupt the calcium, deeper calcium. So that is probably, that's what Sir is hinting. Maybe cutting balloon, cutting balloon, scoring balloon, as well as NC balloon. All three can be used in this scenario. No doubt about it.
Yeah, that's why
the choice is,
we had a discussion whether to just use NC balloon versus cutting.
Yeah, you can go ahead.
Once more. We'll cut the distal lesion at nominal pressures.
Check, no need.
So finally, it is 3 millimeter.
No, it's a 2.5. We cut the distal with the 2.5 at 6 atmospheres, but
only nominal pressures. Yeah.
Proximal 2.5 at 12.
Not more than 6.
2, 4, 6. Take a cine. All right. 6.
Negative air, and I think there's some air. Negative.
Yeah.
Yes. Enough.
Negative. Now let us come to the
I will
major
come
lesion.
back to the main lesion.
Come back somewhere. Yeah,
Yes.
that's where it is. Yeah. Shall we?
Yeah, please.
What is the recommended pressures to dilate the cutting
3
balloon?
could have been okay.
Is there any?
I think
We'll go to 12 atmospheres. 12. 12 is the maximum rated burst pressure.
Okay.
So
We tend to
pretty well.
go up 15, 18 and.
Yeah.
Down.
Theoretically 12, but I think in some situations,
Down.
They are good balloons. So not very compliant. So
Now we can repeat the OCT and see whether any more dilatation is required and whether cutting has done any good.
Dr. Naki?
yeah.
Natarajan here.
Anything?
Hi, Natarajan.
Yeah,
I
then
said, in which situation you will prefer a cutting balloon over a non-complex balloon?
Contrast, I think we'll
Take
do 3 NC balloon
what is not needed.
I think
Rota is not needed. Cutting balloon versus NC balloon. How will you make a choice?
see, I totally agree with using a cutting balloon in this case because of the fibrosis. I was only warning people because you saw the disruption as well as the dissection in the with the NC balloon dilatation. be careful cutting balloon. If you overinflate or oversize it, it can create a lot of problems in the media and adventitia, because there could be hematomas which would form. But in this particular case, cutting balloon would be definitely a better choice because of the fibrosis. There is no question about that.
In the pre-imaging era, how do you know whether a lesion is fibrotic or not? Trial and error.
That is a visual assessment you have to make from your experience. There is no way you can predict.
I think, Matthew, those days we used to look for calcium on the screen.
Yeah, that's right. Only screen.
So that guides us whether to use a cutting balloon or a lesion is tight, we will rotablate and then think of using a cutting balloon.
Absolutely.
And then you can avoid some
Multiple
contrast.
OCT. That's correct.
I think OCT has changed our outlook, right?
So this is the 3NC.
Without any doubt, OCT has changed. your-
14 at most,
Yes.
yes. 16.
Pre-OCT, IVUS, we needed more technical skill
Absolutely.
for the operators to judge the lesion and make the choice of devices. Today, technology has overtaken the skill.
Yes.
So,
Yeah,
because the OCT and all this imaging technology will tell us what to use and what not to use.
But our optimization has also a little changed after the introduction of OCT and IVUS.
Absolutely.
But it will improve our concept also, because many of the cases are done without OCT. So the knowledge gained from OCT in other cases can be utilized in those cases without OCT also. Gain some ideas, some concepts, isn't it, sir?
See, the penetration of OCT is so minuscule in India.
Yeah.
So, if we were to use OCT for all cases, angioplasty would have been very, very expensive, and it would have been non-affordable for most of the patients.
And
what's your suggestion? Do you think that in coming few, at least a year's time, the cost of OCT will come down? At least the catheter?
I mean, if the catheter usage goes up, see, for example, if we are using 20,000 catheters per year for now, and it goes up to 100 or 200,000 cases a year, naturally all the companies will bring the cost down, because it becomes cost effective for the companies also.
Absolutely.
It's purely the viability of the technology, what is hindering us. Once everybody starts using it, then the price would come down drastically. Just like the stents or these devices, cost came down dramatically once we started using it regularly.
Dr. Matthew and Dr. Pillai, one small practical question. With decades of experience without imaging, both of you, in today's time with the availability of imaging, is there anything you have gained out of it?
Go ahead, Pillai.
That's exactly what I told Matthew just now. Our estimation of lesion, assessment of calcium, optimal utility of debulking devices, all have changed, and the final outcome, optimization, is very important so that we go and sleep at home with peace.
Pillai, are you still?
Rajiv, you can go ahead.
No, Rajiv, you continue.
Yeah.
And
in between I will talk, I will give my opinion about the question Natarajan raised.
Just need to go in a little bit further, and one more dilatation, and then
You didn't go. Come back and go.
I think it's gone.
$16.
Yeah. Yeah, should be enough.
That should be fine. Okay. No,
We
sir.
generally do hand injections, and I think there are many people who prefer
Power injection.
power injectors.
But your
I think as long as
beautiful what you took. You
this
took
should be much better.
injection. Somebody must be exercising really well to do the injection.
Yeah, I think
Second thing, what I found, Matthew, in my limited experience, if your coaxialization of guiding into the vessel is good, then probably 10 cc injection is
Would
more
be
than
enough.
enough.
yeah, very
Yeah, absolutely. I mean, whether Natarajan's question, whether it has made us wiser by using the imaging technology. I mean, as we have seen, every technology has made us wiser every time it has come into being.
That's right.
When it was started, it was only X-ray films and cine films. We didn't have any digital imaging. When the imaging technology improved, we started understanding more of problems what we generally missed, like dissection and flaps and all, which we left out post procedure in the early days. That every technology has made us wiser. So properly you have to adapt it, but you shouldn't overuse it and misuse it. Recently I came across a case where a straightforward simple case, an OCT was used, an IVUS was used, a rotablator was used, and an IVL balloon was used. And I don't know for what a straightforward simple case you would have done with a balloon and maybe a stent and got away with it. But overuse and misuse is also hampering development.
We have to strike a balance.
Yeah, we have to.
And most of the time that increases complications as well.
Maximum followed by the 3 millimeter non-compliant in the proximal. Looks like, on one look, it looks like a reasonable preparation. Now let us find
distillation. There is a diagonal. There is a site, isn't it?
So this is the second OCT pullback.
Yeah.
We can, as we come
Start
into
from
the
distillation first.
this is the
anything.
these are the areas of disruption caused by the balloon.
Yeah.
Cutting balloon.
And the cutting balloon.
And here you got some marginal gain of your lumen area, 2.75.
Yeah. And there are some, there's some cut that you can see.
Yeah, in this balloon.
Yeah.
And there's
That's
the branch.
across the
What is the
diagonal.
diagonal?
That's across the diagonal, which is good.
The diagonal ostium seems perfect.
Yes, perfect.
Yes. So now coming further into the middle LED, mid LED. These are the areas further
Yeah, that's
disruption has
where-
happened.
Yeah.
And the lumen area is really expanded well here.
What was the diameter of diagonal on the angiogram assessment?
So the disruption goes to the calcium area.
Can you see any cuts there? Maybe
Is there a
one or
cut
two
at
cuts.
11 or 12 o'clock
At
position?
least 11
nine,
to 12
another one
o'clock
at
you have a
9.
cut. So that will make the stent deploy well in that area.
Yeah. Yeah.
So let's go for a 2.75 into
into
48 millimeter Zine's expedition.
Dr. Natarajan, do you think the diagonal should be wired at this point?
I
No,
don't
that's why
think-
I asked the angle and
Because it's
of the
a
diameter.
roomy diagonal ostium without disease. So it's, I think, quite okay to.
And after all this balloon preparations, it's still intact and completely non-compromised. We
Of
should
course,
be able to.
Of course, there is no harm in putting wire in it.
And even the 2.75 will go up to 3.5, and even the proximal LED EL to EL is 3.75. So you can easily go up to 3.
In fact,
Rajiv, can
when
you
we
fast forward a
that
little bit?
I will just go to that
use
post end. Let's see. We'll go for a little bit.
Hold on. Please.
Shini, please, angio.
No. Now let us see the
Freeze,
the proximal
freeze.
is okay for you right now.
Proximal is okay. We'll have to see the distal.
Now let us go to the other view, the AP cranial view, to see whether we have adequate coverage. Originally, the lesion was about some 6-7 millimeters from the diagonal.
In fact, we have 1 millimeter beyond the ostium. The LID. Let's see the distal.
See?
See?
Seems pretty good, right?
Yeah. I think.
Again, the technical difficulty of the short left main, you have withdrawn the guide a little backward for better ostial coverage of the stent, and that makes the injection more selectively go into the circumflex.
Yeah.
But we are fairly
I
certain
think-
that the lesion is.
I think you can go ahead and deploy.
Shall we?
Yeah, please.
What is the nominal for this?
12.
11.
11.
So we'll go only to 11. Okay.
11.
Okay.
Yeah.
I'm at 11 now.
Yes.
We are restricting to the nominal because we measured the distal to be at 2.5, and this is a 2.75 stent, so we don't want over expansion distally. And then we can work within the stent with optimally sized balloons to match the reference vessel. So exactly at 11, which is the nominal
Can come
pressure.
down, please.
Negative?
Yeah, please. We can have a stent boost to see whether it is open well. It looks quite good, and geographically looks quite all right. Stent boost, please.
Go forward.
Distal. It is,
What do you
we'll do just an angiogram. Just an angio, please. Just.
Looks good.
Diagonal is open.
Some pinching of the diagonal, maybe spasm.
Yeah, that's okay.
I think we can't oversize the LED beyond the diagonal too much.
Yeah.
Yeah. Or what we can do is you can take a 2.5 and go at higher pressures there. Okay.
So 2.5 NC balloon
2.5 there.
and approximately
2.5 or
3.5.
2.75. 2.5. 2.75 short, 2.75 balloon. Then given nitroglycerin and then 3.5 approximately. That's right. 2.75, 12.
That's okay.
12,
12.
2.75, 12.
So let's take a 2.75 into 12 and we'll I'm at 12,
14. Yeah.
14.
Yeah, I think that should be enough. Down.
Shall I?
Yeah, please.
I'll go to 16 here.
Yeah.
16.
Yeah, that's the side of the tightest lesion. Down. Get a little bit.
That's correct.
You want to take a
And
stent boost?
Yeah, that's good.
We are fine.
Yeah, you can dial it once again.
Want to see it?
Yeah, please. Fluoro.
Shall we?
Yeah, please.
How many pressures? 12.
12,
is okay?
14. Yeah, 14 should be enough. Yeah.
All right.
Yeah.
Negative.
Can you stent boost?
We'll wait for it.
So we haven't missed any intervening segment.
with the diagonal?
No. Anything? Any concerns at this point?
Not really.
Not really.
The only concern is whether we really landed the stent at the true ostium. Or is there still some ostium
Yeah, we
before
could
the
have come
lesion?
back 1 millimeter, but I think that's all right.
Because we were limited by the requirement of the stent distally.
Not only that, that's disease-free area. Yeah. Okay.
Very good.
Looks good, isn't it?
What was the diagonal ostium you thought?
Show the angio, Sri Lakshmi. Have you saved it? Was the diagonal flowing? No.
It's okay.
Up to the ostium, sir.
Yeah. That's at the ostium. Stent display.
So this is the
Stent is well
post-PCI
expanded.
pullback. As we go by the MLD max algorithm, the max part demonstrate to check any kind of medial dissection. We come to the distal part of the stent to just see whether any kind of dissection is there. Apparently there is no dissection distal to the stent, and we come into the stent to see any kind of opposition.
Slowly.
So as we come into the stent, you can see the lumen area
That's the diagonal.
everywhere.
That's the diagonal ostium.
4.5.
Can you show the diagonal ostium, Santosh?
Yeah, that's
So that's
little bit.
yes.
We go back a little bit.
Here the MLA is 4 millimeter square in that area.
Go back a little bit. Can you show the ostium of the diagonal? Yes.
That's the ostium. Well open.
It's well opened. You can see that figure of 8 here. And we further come further coming to the proximal side. Everywhere you can see the well expanded stent. And the stent is well opposed. And
The area here is all more than 8.
more than 8 as per the criteria. Post PCA we need minimum 4.5 millimeter square. That is seen everywhere here more than 4.5. And also you can see the white bar which clearly indicates that the stent is well expanded and there is no malopposition across up to the proximal
No
part.
red dots, so
Yeah.
indicating that the apposition is good.
And also now look at the last piece of the MLD mag, that is the expansion. Expansion for that we keep the stent both the distal edge and proximal and see what is the, either you divide into 2. Expansion here it is showing area stent is 35, so this almost 100%.
Okay,
The area stenosis is absolutely 0.
Okay.
So your proximal expansion is well above your accepted limit, which is 100%.
Do you want to
So the
So the
distal is
stent
only
expansion
in
is
comparison with the proximal, isn't it?
No, he did.
Pardon, sir?
He divided the area into 2.
2.
Yes.
No, that is part of it was proximal to diagonal. So area beyond the diagonal is the vessel. It's really smaller, so we can't.
Because of the
In our-
tapered nature, we couldn't get the expansion as per the criteria. But when it comes to proximal, the stent is well expanded and quite acceptable.
Not only that, when we initially did the measurements, the distal was 2.5.
Yes, sir.
And we have stented with the 2.75.
75.
So I suppose it's an acceptable result.
Quite true.
So we
You can
have
do
another 2 minutes for the
Can you
session.
show 3D of the side branch?
Absolutely.
You can do the bifurcation view
Now
as
we will
well as
come
the
to the
flight.
bifurcation view, how much threads are across the side branch. So from the OCT system, we go to a software called the 3D bifurcation, which will clearly demonstrate the bifurcation view. And this all pink dots show that there is bifurcation.
Yeah, so it's a
Rotate it.
This is the distal bifurcation.
It's a widely open diagonal ostium with a strut, a Y strut across, but not limiting flow at all. Yes.
Okay.
that's
Show the
quite-
fly through
that's-
image and then we will do a final angel.
That's quite.
Excellent.
So even the fly through view, so you can see clearly well opposed struts inside the lumen.
Here also you see
Completely.
red dots when there is less expansion.
Plus tapering,
Okay.
or we need to do anything further again. Yeah.
The most,
Distal most.
distal most
We can do
segment.
that. You can give a 2.75 NC balloon. We'll keep it 1 millimeter before the last strut.
Absolutely,
And do
sir.
it-
But we
now that we
dilated
have
with
this-
2.7.
Only the stent.
Only the stent, yeah.
But when we did the post dilatation, we used a what was the
We did
first
the
post
2.75.
dilatation?
Used a 2.75.
But did we go up to the distal
Yeah.
master part of
Yes,
the
yes,
stent?
yes. 1 millimeter approximate. With,
Then we have done.
yeah.
What more work?
What's the area there?
What is the distal,
Distal,
most stented area, MSA? 4.33,
3.
which is well within the.
I think it should be all right. We have gone with the 2.75 balloon, NC balloon at 12 to 14 atmospheres distally. And I think it's
So
expanded
your
well.
calculation of the distal expansion should also take into account tapering of the vessel, major side branches before, etc.
Absolutely.
And we have almost reached the EL to EL dimension,
NTG, please.
which should never be violated, and we'll stop with that. Right. NTG, please.
Thank you.
We'll take it angio, final angio, and then
Go ahead. Triangle is flowing, right?
yes. I'll pull back the wire. Generally pull back, otherwise it might just jump out. Yes, let's see. Sini?
Shall we?
Yeah, Sini.
Go ahead.
Yeah, it's good, I think.
Excellent.
It's a small septal. Having an Timmy.
Thank you, Rajiv. Thank you, Natarajan. It was a wonderful case.
The initial
A long lesion, calcific.
lesser now
It's better.
after the post dilatation.
Fibrocalcific.
We'll take one more
which
shot
was
in some other orthogonal caudal view or something.
Yeah.
You do the same LAO caudal view.
Now we can clearly see that the separate origins.
That's correct. Our stent planted exactly at the ostium.
When our ostial is also
Don't
fine.
you think so, Dr. Rajiv?
Yeah, I think so. So we have completed this case, and when we started, we thought it would be a fully calcific vessel, and I had a strong feeling that it was either a short ablation or an IVL.
Thank you, Rajiv. Thank you, Natarajan. It was a wonderful case. A long lesion, with a separate origin of a lady with calcium, and the imaging clearly showed that it was a deep calcium closer to the adventitia, wherein the role of preparation is through with either a non-compliant or a scoring or a cutting balloon, and use the cutting balloon judiciously, and got a great result. And you expanded the stent well, and the imaging clearly showed us how it helps to optimize the stent dilatation. That was a great case and good learning. Thank you once again.
Thank you.
We have a live case coming at 8:30, so we have to be on time. That's why I think because of lack of time, I think we'll go to the next presentation.
Thank you very much.
It was wonderful. Thank you once again, Rajiv and Natarajan.
Thank you.
I invite Dr. Samuel Matthew, from whom we have all learned. We continue to learn from you, sir. I invite you for your lecture on calcified ioto-ostial lesions, my approach. Please, the stage is yours, sir.
Are you with us?
Sir, yes, sir. We can hear loud and clear, sir.
Okay. See, when Deepak told me to talk about a case where there is an ioto-ostial calcification, I said it will be, I don't know which case to present. Luckily for this meeting, what happened 3 days back when we picked up a patient, we found somebody which would fit in to the criteria looked for Deepak. This is a 77-year-old male. I'm just going to show you a case, and I've recorded, because I knew that I have to make a presentation today. I recorded everything step by step. Issues, problems, what was my thought process, and how to handle it. So I'll go through pretty fast. Anytime you want to interrupt, please go ahead and interrupt. Otherwise, I'll continue, because otherwise we won't be able to fit in the time schedule given. This is a 77-year-old male who had multiple interventions, had a PCI for the left main, LAD, proximal circumflex, and proximal RCA. You can see the LAD stent in the left main, also LAD and left main patent. There is good antegrade flow. The lumen is well preserved. Circumflex stent is just beyond the ostium, but the ostium, there is a pinching, there is a narrowing come back, but distal vessels are not so large, so we decided not to intervene for the present. This is a case we have to handle this right coronary artery. Is a huge artery. For an osteopathic, I am not unable to cannulate the guiding catheter. It's staying outside. We have to. There was definite calcium at the ostium. There is some calcium in the. There is a stent here in the proximal right coronary artery that is very difficult to identify whether it is calcium or only the stent. But it appears that there is some calcium in the stented segment, but no ISR there. The stent is patent. Just beyond stent, before the bifurcation into PDA-PLB, early bifurcation of PDA-PLB, you can see a very tight lesion in this view and also in this view. And in an RIO view, it is more relevant. Look at it. Very tight lesion, a blob of calcium sitting at the bifurcation. This is what we have to handle. So what was my thought process? What did I think? I said, the biggest branch is the PLB, which is going and coming down. The PLB is the one which is coming straight. So whatever we try to do, we have to somehow preserve the PDA. That is the most important artery. But unfortunately, it is taking off in a 90-degree
angle.
And the chunk of calcium is sitting at that ostium. The challenges were, first of all, wiring. How will we wire that and what wire is our choice? Generally, I would prefer to use the workhorse wire, whatever I am very comfortable with. In a routine cases, I would take that wire out first, and if that doesn't work, I may switch over to more specialized wires, which I am not very great in handling. And so my workhorse wire is a BMW wire. I took that wire. Although if that doesn't work, my strategy would be a Xeon black or Xeon blue or Whisper. Any one of those wires should work. But those wires also have disadvantages, which all of you are familiar with. I'm not getting into those details now. So we are wiring wires in RIO view. You can see I didn't manipulate the tip. I left the tip as it is. It's better not to meddle with the tip. What the factory supplied tip sometimes is better than what you try to make it. And the tip has gotten. So what you have to do is, in RIO view, you have a disadvantage of not able to manipulate or judge the guiding catheter because it keeps on slipping out. You know that we couldn't engage the guiding catheter. It is sitting outside the ostium. So you will have to switch back into LAO before you advance. Otherwise, before you could realize, the whole thing will flip out. So move to, which we did, move to the LAO and then position the guiding catheter. You can see the guiding catheter is in good position. Get the wire down. This is a BMW wire. What was our intention? Our intention was to take a microcatheter because wiring that, and there is chunk of calcium. We need a rotablation. There is no doubt about that. And and OCT, none of the catheters we are able to get inside the vessel. There is no way we can document that. So strategy was to get a microcatheter, but microcatheter doesn't track down. And while manipulating, you see the guiding catheter slipping out. You have to be very, very careful in handling that. You don't panic when the guiding catheter slips out. You can come back with the guiding catheter. That's why I have kept these frames of pictures. You rotate clockwise and come down and give a tug on the guide wire, and you can re-engage the guiding catheter. This is extremely useful step you should know. Now PDA, we are not able to wire. What next? The thought process was this, anyway we have to have a rotablator there. We have to have a rota wire there. So the other option is when PDA doesn't work, try to get into PLB. That's what we did. You can see I have got my BMW wire into the PLB, but here again, same situation. You can see the last frame, the microcatheter doesn't go past the lesion. We are stuck there. Idea was to go ahead and get a microcatheter there and then exchange to a rota wire. That is not possible. Then what next? The only way is get the BMW wire out and get a bare wire, rotablator wire in. It is challenging, no doubt, but it is possible. That's what we are showing you. You can see the rota wiring here, rotablator wiring. You see how we have very gentle curve and be very careful with your manipulation. You have got a support of microcatheter on top. I have not brought it down because if I try to bring it down, the whole thing will flip. And once the wire goes past, then advance the microcatheter little more and then get a wire into the PDA and into the PLB. With that, now we know that the ostium is diseased. This is the time to rotablate the ostium also. And we have to disengage the guiding with only a 0.10 wire, 0.9, the rotablator wire inside the coronary, and you must get it as deep as possible, otherwise the whole thing will come back. And you have to disengage the guiding, the right coronary guiding. You know that has got an inherent torque. You must hold the catheter in such a way with your left hand while manipulating that without losing the ostium alignment. And then keep the guiding catheter or seek somebody's help, whoever is a skilled associate you have. You can ask them to give the torque control and watch the movement of the rotablator burr. And slowly get in, you can see it moving in slowly and cutting that ostium, and the purpose is done. Then you can engage the guiding a little bit, and we are trying to cut the calcium. We had lots of difficulties. Multiple runs had to be taken before the ostium, before the calcium was cutting. You can watch. In the last frame, you can see actually the burr going through the lesion. With great difficulty it crossed. But meanwhile, don't get impatient and try to jam the burr in, then you are in trouble. This is a very short lesion. This is the one which can trick you down. If you put too much pressure, the burr will jump through, then the burr will get stuck beyond the lesion. You will not be able to get it out. You will face an emergency situation. You have to be extremely gentle without dropping the RPM. You keep moving with a lot of patience and get the burr across the lesion and then do a couple of polishing runs. That's what we did. And here there is another warning I want to tell you, that the PLB is not a very large branch. So don't try to take the burr too much deep in. You will get into trouble. Even with this technique, you can see there is a significant slow flow as soon as the burr got across the lesion. So first thing what you have to do is get the burr out. And as soon as we do that, we have to get going with the PDA. Before you bring in any balloon or anything, you must get a wire into the PDA, which we are doing now with, again, a BMW wire. got a BMW wire into the PDA, and once we have that, exchange the rotablator wire. You can see a microcatheter going down, and we exchange the rotablator wire into another BMW wire. So we have two BMWs in position, quite comfortable. Now, what do you want to do? We have to dilate the lesion. The mid-RCA lesion and the PDA ostium was pre-dilated with a 2.5 NC balloon. We didn't have much struggle to get into that because it is already ablated. The balloon dilated. Then we further dilated with a 3 NC because we have to get a stent in. In the last frame, you can see I've got a 3x28 sign stent, but no way I could deliver the stent because it wouldn't take that curve. Even though we have pre-dilated very well, it wouldn't take the curve. Then what next? We said we need to engage the guiding catheter. The ostium is not prepared. We have to look at that ostium, prepare that, and also another purpose, we need to get a guide liner, because if I have to get a stent into that, I need to get a guide liner in. So what we did is got a 3x6 cutting balloon, 3.5x6 cutting balloon, cut the ostium very well. Then we were able to engage the guiding catheter without any damping of the pressure. You can see in this picture, the ostium of the PDA is very well dilated, but still we couldn't get the stent in. So we want to prepare the ostium, which we did, and got a guide liner in. In spite of guide liner, also we are not able to deliver the stent. So then what do we do now? We have no choice. It's very difficult to manipulate a guide liner along with another wire in the guiding catheter. So we are removing the second wire. You can with difficulty, but it is easier to manipulate with only one wire. Now what next? We have to get the guide liner deeper, otherwise we will not be able to deliver the stent. Sometimes it is possible to take a smaller stent instead of a 28 millimeter stent. Short stents you can put. The problem here is if you put a short stent into the PDA, then you have to follow it up with another stent. When you bring the second stent in an angle which is 90 degrees, your stent metal to metal will get stuck in the other stent, and you will now be able to get past with a short stent. So you have to have an optimal size stent if you want to get an optimal result. So what we did, with the guide liner, it is not working. So it is not tracking. So what we do is, see the guide liner. We used a 3 millimeter balloon and inflated into the PDA, anchored that balloon. On that anchored balloon, we advanced the guide liner, which you can see here. The anchored balloon is here, and advancing the guide liner towards the balloon and bring it closer to the balloon, taking that angle. And once you do that, you are able to deliver the stent without any difficulty, which we have done at 3.5, 3 millimeter stent. So that is done. Once we did that, we have to rewire the PLB, which we are doing with the same BMW wire. We crossed into the PLB. You have to have little patience, you will be able to get across. and pre-dilated, then put a short stent there and did a kissing balloon and followed it up with we know that we have done a cutting balloon dilatation of the ostium. That area also has to be stented with a 3.5 into 15 Zions. And this is the final result we could achieve with that. So this is the pre and this is the final result. So I took you through a case which we did 2 days back, and all sequence of events and your thought process, what next, what next. You shouldn't get stuck with one option. One option, if that is not working, what are the ideal second option? You have to keep switching, and we are able to achieve this. So challenges are there. Unless you are ready to face the challenges, it's very difficult to improve yourself in interventional cardiology or any phase of any field of cardiology or any field of life.
Thank you, Matthew sir. It was a wonderful case, a true master class, and difficulties at multiple levels. Like it was an extremely calcific lesion, severe osteal lesion not allowing the guide to sit, plus you have a tortuous vessel, plus you have a 90-degree bifurcation, very early bifurcation of the PLV and PDA, wherein wiring itself is so tough. And in this lesion, how to manage. It was a true master class from you. A lot of points to be learned here, from how to handle the guiding catheter, how to wire this, and how to anchor the guiding catheter, how to anchor the guide liner to get in, and then every aspect of this case, is it's a true learning. Thank you for the wonderful case, sir.
Not at all. It's my pleasure. Any doubt, any issues? Anybody wants to comments or comments? Srinivas or Pillai or anybody?
Sir, can
Matthew,
you
sir,
unshare
it
the
was
screen? Sir, can you unshare the screen? Thank you, sir.
Yeah.
Hi, sir. It was a pleasure to watch how you took us through that case with all those challenges. I have one question. After the balloon dilatation of the ostium of the RCA with the cutting balloon, would you have thought about changing the guide catheter to an Amplatz or something?
I mean, that's a fair question, but I didn't think of it at that point of time. The sequence was working. If it was not working, I would have switched over to an Amplatz. Actually, today we did a case, a similar situation, in spite of doing preparation, everything, and having a guideliner in not able to deliver the stent, we changed over to a Amplatz one and managed to do that. The major disadvantage with an Amplatz and an ostial lesion is your positioning of the stent in the ostial position with the Amplatz guiding sitting into the ostium. It's very difficult to disengage the guiding catheter once in position. If you disengage, the whole thing will flip, and positioning of the stent will be very difficult, very challenging. So try and avoid using an Amplatz guiding in presence of an ostial lesion of the RCA. That's a challenge. Yes, Govind. No, you are muted. Govind, you are muted.
Yes, sir, please unmute.
Sampath.
Sir, what about using a extra strip wire into the
Absolutely.
stent?
Sampath, I just wanted to introduce that. That's a beautiful demonstration of addressing the ostium and the calcific lesion. Now, I have seen you, we have washed up together also in some cases. How difficult it is to burr the ostium. Have you used an extra support wire, or you are comfortable with this regular wire? And as far as the guidezilla, especially in such curved artery with calcium, I'm sure you will always use a balloon to take it forward, isn't it?
Yeah. See, coming to the extra support wire, probably extra support wire would have been would be a more stable wire, but I am not very comfortable using an extra support wire. I'm so comfortable using the standard conventional.
Is it for the right coronary or for the left?
Both for the right osteolation, both right and left, because just like why did I use a BMW for such a tortuous lesion? That I know the wire behaves well in my hand. So same way.
Yeah, that's true. But
so
would you suggest?
Whatever comfortable with you, you should use that. You can upgrade it only when you have a problem.
On a Judkins, normally the wire will try to sag into the sinus, right? Unless you hold it precisely with tension.
It's a tightrope walk. You have to have the right torque on the guiding. You have to have somebody to help you to give that torque and then control the berth. This is difficult. Unless you keep doing it, it is very, very difficult to explain, but it's a challenge. But
as usual, this was an excellent demonstration.
Thank you. Thank you so much.
Thank you, Matthew, sir.
Thank you.
Case. Lot of learning points for the youngsters, sir. Yeah. Thank you.
I'll be with you for some time. In between, I may leave. Please excuse me if I go missing in between.
Yes. I will go to the express.
Hiramat, hi.
Hi.
Welcome, Dr. Hiramat. I request you to present your presentation on calcified left main application, my approach. We have the one of the senior most interventional cardiologists in the field of cardiology in our country, from Ruby Hall Clinic, Pune. It's wonderful to listen to you and learn from you, sir. Please go ahead, sir.
Good evening, everybody. So we are talking of calcified left main bifurcation, how one would like to address. When we talk of outcomes of anatomical versus functional testing in a coronary artery.
Sir, kindly share your slides.
You're not able to see those?
No, sir.
Are you able to see the slides?
No, sir. No, sir.
Not yet, Dr. Hiramat. You will have to share screen. That green arrow you have to click on in the lower bar.
Go to Zoom, sir. Sir, go to Zoom, sir. Yeah.
Yeah, we can see. We can see.
Go to slideshow, sir. Yes, sir. You can start, sir.
All right. So we know from the anatomical versus functional testing that they could go run pretty parallel, though functional testing is relied upon heavily these days. So when we talk of high risk coronary atherosclerotic lesion, we have these kind of differences when it is high risk. And especially when we talk of a high risk in the left main, the difference would probably get widened. The CT angio actually tells us a lot of things inside the vessel wall. And the CAD severity by CCTA can sort of look at the inside the vessel wall. So low attenuation plaque, positive remodeling, napkin ring, and spotty calcification. All these would sort of tell us that the plaque is not very safe, and we need to worry about doing something very effectively, very strongly. This is another case where we can see both the coronary ostia are originating from the same sinus. It was very difficult to cannulate the left. In fact, after a long cath lab time, we discontinued, got a CT angio done, and then again we brought it back. And then this is on day 2. You can see a big diameter EBU catheter sitting well into the ostium of the left coronary artery, which was originating from the right sinus. And then it showed all these lesions. This was another case. You can see cross ST depression. It was happening again and again. And what is also important is ST elevations in the AVR. And predictably, this gentleman had a totally occluded left main. The right was dominant, normal, luckily, and it was supplying the entire left circulation, which was cut off at the ostium. This was many years back, and we thought it safer to send him for a bypass surgery, though things would change. Can we manage medically? I think that is another question when we talk of left main lesions. This is a case who had a functioning lima. He, in addition, had a stent which was not functioning very well. In addition, there was a lesion in the left main, and we felt we should do this case with medical treatment. And then when we look at the ischemia study, the CT angio was one of the winners, and we could sort of believe from the previous case which I showed you that the CT angio information is quite useful to cannulate. Then we have this relation between calcium and the outcomes. So higher the calcium, worse are the outcome, and you need to probably work very hard. Then the imaging with OCT also tells us that there is an incomplete expansion of the stent when we have very hard lesions in the wall, especially calcified walls. And this is why we need to make a good preparation. So this was a gentleman at age 29, he had an inferior infarct which was stented. At age 42, some 13 years later, he had ectasia and a critical lesion beyond the diagonal. So this was done with Zymes, which maintained flow to the diagonal side branch. And this ectasia was covered exactly with a covered stent, so that flows to circumflex and flows to diagonal were very well preserved. 7 years later, he comes back with ISR re-narrowing at the mouth of the LAD and mouth of the circumflex, which was again stented, and a patient continues to do well. So this is one area where I think if you don't sort of pay enough attention, patient would probably come back. This was a young 36-year-old who had bypass surgery. However, within 3 years, he has come back, and now he has a lesion left main to circumflex, which was not stented or not grafted, and also a lesion in RCA, which was leading to PLV, and there was a lesion at the mouth of PD, which was grafted. So we needed to work on these two, and even at this young age, the left main was quite a challenge. This was another case. Patient had anterior MI. That time, the right coronary artery was looking very normal. Within 1 month, you can see the date. Within 1 month, patient has come with an acute inferior wall infarction, and which was stented as an emergency angioplasty. However, 1 month back, when he came with an anterior MI, this was the position of the LAD, and he was classed for medical treatment. While during the inferior MI, you could see clearly worsening of this flap. And 1 month later, we actually called this patient back to fix the left main LAD. The stent reaching D2, and you can see flows to D2 and D1 are very well preserved. So this is how the sequence was. First, the anterior MI classed for medical treatment. 1 month later, inferior MI, angioplasty done. And since the flap was worsening, we decided to put an electively a stent in the proximal LAD starting from the left main. So this is a case which is it sets you thinking as to where the stent should end. So we do IVUS towards LAD and IVUS towards circumflex, and both the mouths, they look quite good. So the stent actually ended at this stage. Now this was many years back, and the patient did really well with a stent which was ending just at the mouth of the left main. I don't know if I have to do this case again today, whether I would end a stent here, or we'll probably bring the stent to one of the branches, whichever is bigger. So the information obtained on CT is quite informative. You can know a lot about calcium. Fluoroscopy also tells you that the vessel is calcified. However, imaging from inside gives you a lot of additional information. Like in this case, the IVUS is telling you the arc of calcium, and the OCT is telling you sizable calcium in the vessel wall. So all these led to some kind of algorithms which you and I use to decide what is going to be best for your patient in the left main. Mind you, this is one area where you probably would fear about restenosis and would not want it at any cost. And you'll probably take many extra steps to avoid a possibility of restenosis. And this is a comparison of the information obtained from the angiogram, the CT angio. In fact, if patient has a CT angio, I use it extensively to plan my procedure. When you're doing a left main, IVUS, then IVUS VH and OCT. So whatever information they are giving you, I think you must sort of use it for planning this kind of left main. And there could be many algorithms which can tell you how to go about. So the technologies that we have for calcified lesions, the rotablator is probably the oldest. The OPNNC is gaining a lot of importance. And the beauty is it doesn't swell, and will probably exert a strong force on the vessel wall to crack the calcium. Cutting balloon, of course, is another way, and IVL is gaining a lot of popularity, and you can see why there are so many positives on IVL, which help us to decide how the calcium can be handled in left main. So all these techniques are probably helping us to avoid surgery and get a left main calcified to be done with angioplasty. So this is actually a run which tells us about the calcium in the vessel wall. And then based on what you are seeing here, you can plan your procedure. So you can use different techniques, cutting balloon, IVL, rotablator, or whatever, and then probably end up with a technique. In this particular case, we have left main, in addition, a sizable calcium with a critical narrowing at the ostium of the LAD. So this was a vessel where we thought we would use a rotablator, and this was used left main to LAD, including the mid portion of the left main. So this was the picture at the end of left main. IVUS is showing sizable calcium, and this is how we ended up after rota, a stent which is coming back into the left main, and the mouth of the circumflex is fully open. So imaging becomes a very important modality when we have calcium in the left main. So the risk of
Sir is facing some internet busy.
more than 0.5 millimeter, and calcium length is long. So all these are probably telling us that you would probably struggle to get a good stent expansion. So this is a case where you can actually see a lot of calcium. However, after imaging, we also had some element of thrombus along with calcium. And the story was like an ACS. So we preferred using a cutting balloon towards both, avoided rotablator for the fear of getting distal embolization. And this is the final result. Luckily, I think the angle between the LAD and circumflex is quite wide, and that helped us to get a good result. So imaging becomes a very important modality when we are dealing with a left main. It helps you to plan your procedure and also tells you whatever you have done is going to work for a long time. Circumflex left main was done with these 3 stents placed. Patient was told to come back for a left main, but I think with these 2, circumflex and RCA correction, he improved so much that though he comes for follow-up, he refuses to come in for a LAD angioplasty. So these are 2 important ways in which we handle calcium. And for left main, I would probably feel that the shockwave balloon is probably going to be more helpful than the rotablator. Like in this particular case, you can see the there's a critical lesion at the mouth, and patient was heart failure. So we did a balloon IBP, and then did a shockwave balloon towards LAD and shockwave balloon towards the circumflex. This, I don't know, but probably avoided distal embolization, which would not, and then this, so as I mentioned to you, the CT angio, if it it will probably help you to make a decisive techniques. So this is a LAD trifurcation. I'm showing you this because so many times at the end of left main, you see a trifurcation like this. And since the diagonal was a big vessel, the main stent went here. We did a tap towards LAD, and the question was whether to address the diagonal. We did balloon since it was not looking nice at the end of 2 stenting, and then finally had to put another tap to the diagonal. So we ended up main stent going towards diagonal 2, tap towards LAD, and a tap towards diagonal 1 to give us this kind of nice looking results, which are good on follow-up. Is it for me? How much time do I have? Okay.
Another minute.
All right. So we have these complex PCI, and a laser, I guess, might come very useful in coming years. Calcium in the left main is quite a difficult subset. In this particular case, we had calcium in the right corner.
I think we lost the connection, I think.
Can
Yeah,
we
connection we lost. Yeah.
Yes, sir.
Interest. Dr. Hiremat, are you there? I think we lost him. I think then there is a net connectivity issue, I think. It was a wonderful presentation. Dr. Hiremat? Yeah, we saw some wonderful cases actually. How to manage the calcium in the left main. The role of IVL, the role of atherectomy, I think Dr. Hiremat showed all the 3 varieties of lesion preparation. And anyway, calcification lesion preparation is the most important thing, so that you can deliver the stent, and the stent expansion to optimal level decides not only the acute result and long term, it also decides the long term result. And he showed the impact of the imaging and the role of imaging, how to understand the calcium distribution in the left main bifurcation, and also showed us how to manage with different techniques, the one with the OPN balloon and another with cutting balloon, and the rota as well as IVL. Any other input from any other panelists?
So Dr. Louis and Dr. Sampath is there.
Dr. Sampath? Yeah.
Dr. Srinivas, he showed beautifully about how imaging helped in calcium and the management of it. Predominantly, he showed something about OCT, the rule of 5 and the calcium 400. Do we have anything like that for IVUS? How do you assess the calcium and plan?
The same criteria as hold good actually. It is the arc of calcium and the length of calcium and the thickness of calcium. That the same thing holds good even in IVUS. The thing is the resolution, the thickness is better appreciated in OCT than the IVUS. IVUS actually picks up the calcium very well, the arc as well as the length, but the thickness cannot be assessed so well because the spatial resolution is much more with OCT than the IVUS. But both technologies are quite good for the calcium in the vasculature. No doubt about it, Sampath. Yeah. Dr. Pillai, you had a comment to make, I think. Yeah. You're muted. You have to unmute, Dr. Pillai.
Can you hear me, please?
Yeah, now we can hear you.
Yeah. How much hemodynamic support is given by an IABP when we are using such a IVL balloon in the left main? Or if the patient's hemodynamics are disturbed, Impala may be a good decision, which you should keep in mind. And although it is
Absolutely.
expensive.
Absolutely. Yeah, hemodynamics, especially if there is LV dysfunction, I think it's extremely important to have hemodynamic support system. Impula would be a better choice than the IABP. I fully agree with you, sir.
I think Dr. Hiramat has come back. Does he have any comments where he had problems while handling such patients?
Well, I think I'm very open about which way to go. And that's why when we assess, like an angio is done, there's a lot of echo. I don't know whether it is bothering you. I hope it is not from my mic, but
we can hear you well.
All right. So I would probably take help of everything that is available. Like if the CT angio is done earlier, I would get into details of that, make a choice beforehand, and then I'm very free. I mean, if patient wants to go for surgery, I would even send them for surgery. But yes, I think all these IVL, the OPN, of course, age-old rota, all these are very important in making a good result for a calcified left main.
Absolutely.
Dr. Hiramat, it was a wonderful presentation. A lot of cases, actually, learning cases which we saw from you. Thank you, sir.
Thank you.
We will go to the next presentation by Dr. Chedda on the imaging modalities to understand the cancer-like lesions. Dr. Chedda is a senior interventional cardiologist from Commando Hospital. He is actually visiting even Jaideva Institute to teach our fellows. He has a wonderful experience in the imaging modality. Let us hear from you, Dr. Chedda.
Thank you, Dr. BC. Thank you, Deepak, for giving this opportunity. Over the next 20 minutes, if that is the time allotted to me, I will just take you through the role of imaging in the coronary calcific plaques. We know that about 6 to 20% of PCIs which we do in our practice have a considerable chunk of calcium, and I've had the pleasure of listening to two of my senior colleagues. They gave wonderful talks and they explained as to why the long and short-term results of these PCIs are poor. This is probably because you either have inability to deliver the stent or you leave under expanded stent. So the MACE rates are phenomenal, as you can see in the slide from a recent study by Samir Sharma Group, which was published in Cash Cardiovascular 2019. And if you look at the profile of these patients, majority of these patients with the calcific plaques are older, because we know the younger patients are presenting with unstable plaques which rupture with erosion. And if you look at the comorbidities, they will be hypertensive, dyslipidemic, CKD and diabetes, very, very commonly seen in this subgroup. And we can assess the calcium. Dr. Hiramat very nicely explained that you can use the CT, IVUS, OCT, but in the labs where IVUS and OCT is available, I think they are playing an ever-increasing role in assessment, because they give you true assessment and they give you the distribution of calcium in these calcific coronary plaques. And what are these patients coming to us? They are generally coming to us with stable coronary artery disease, or some of them are coming with heart failure. They have developed multivessel disease and they have developed ischemic cardiomyopathy. Very, very rarely you will find ACS in a calcific milieu, which is very less, and it's essentially confined to subsets of lesions where you have spotty calcium, or subsets of lesions with plaques where there is underlying calcific nodule. Well, is imaging important? I think it was highlighted by Dr. Hiramat that imaging is very, very important. Just here, a tubular lesion in the mid-LAD, which was probably stented well, and this was the final result, but the operator felt that there is something wrong and the stent is underexpanded. He did OCT, and now look at the findings. The distal edge is absolutely fine, the proximal edge is absolutely fine, absolutely no problem. Now look at this. This is the overlap segment where both the stents were there. There is a big nodule underneath the stent, and this is at the point of underexpansion, big nodule, overlapping stent struts, and you see the eccentric stent expansion. Now, this patient is certainly going to come back in a short while with stent failure. So, imaging does add on. We could have at least taken care of this nodule, or we would have sized the stents properly so that we don't leave overlapping stent struts in an area where there is a big nodule. Well, coronary angiogram is basically used in majority of our cases because we feel that this shows us everything. You can see the calcium. You can classify them into mild, moderate, or severe. I'm not going to go into the details because we've seen that. But imaging is playing an ever-increasing role, and see the increase of sensitivity from 38 to 73 and 90% with IVUS and OCT. IVUS is much more sensitive because it picks up spotty calcium. It's got a greater depth, so it can show you deep calcium very well, whereas OCT is a phenomenal tool in that it, as Dr. BC was telling, it tells you not only the extent but also the distribution in terms of thickness of the calcium. It is unmatched in terms of stratifying these lesions. So what are the calcific plaques which you get to see on the OCT? This is the commonest thing which you get to see, superficial calcific sheet, which is seen in about 67%. This could be thick or thin, segmental or circumferential. When multiple of these sheets coalesce with each other and erupt into the lumen, they form what is called a eruptive calcific nodule. And rarely you will find these plates protruding through the lumen and what is described as a calcific protrusion. Calcific protrusions are generally benign. They are not going to produce any major symptoms, and in majority of the patients do not require any treatment. So let us compare all these three types of OCT-based calcific plaques. As mentioned, calcific sheet, the commonest, and it's basically plates of calcium which are there in the subintimal region. The nodules are commonly seen in the RCA, whereas calcific sheets are common in the LAD. Luminal narrowing is majority of the cases is produced by the calcific sheets is relatively less, and I mentioned in protrusive nodule, nothing much happens. Well, look at the other things, association with ACS, mainly with the superficial calcific sheets, and very less with the eruptive nodule and none with calcific protrusion. White thrombus is what you get to see, the calcific sheet, red thrombus. So protrusive, the eruptive nodule which forms by the multiple plates of the calcium and the clot forming over the surface, so that gives the irregularity over the surface. Calcification index implies that what is the extent of calcium in the vessel, it is much more with the eruptive nodule. And in majority of the situations, you need atherectomy devices, which should be balloons or could be root ablation or IVLs. Calcium fragmentation is common with sheets, frequent with eruptive nodules, but not seen at all with the protrusive nodules. Stent failures, I'll be coming to the later part of my talk and I'll be elaborating on how these stent failures occur in these patients. And we need to stratify. And Dr. Hiramat has already, and the other speakers have already spoken on this. I'm not going to speak on this. I'll just show you a case example where calcium volume index can be used. This was a case which I had done recently, about 2 weeks back in Jayadeva. So when we assessed this on OCT, we measured the calcium thickness of 1.3 millimeters. There was circumferential calcific arc, which was almost 360 degrees, and look at the thickness of this arc, phenomenal. And when I looked at the calcium length, this was about 40-50 millimeters. So CVI score is greater than 4, and with this extent of calcium, I'll be showing this case later. I'll tell you how it helped us reach our decision. So as the calcium arc increases, the stent under expansion becomes more frequent, and there is a need to have an atherectomy device. You will need to have some kind of plaque modification tool on board with you. Well, these are the atherectomy devices. We've, I think, heard of all these devices. Let us see some case examples. The first case example is of a superficial calcific sheet. There was osteal LAD disease, which is seen here, was tight in the caudal views. We did the OCT. On an OCT, we noticed a thin plate of calcium. So we used a cutting balloon, and when we post-cutting balloon, when we looked at the cuts, this is the film which shows you that the plaque has been opened well and has been cut by using the cutting balloon. And there is a dissection plane which is seen near the thin calcium plate. So how does OCT help in such situations? This was the final result. The OCT helps because it tells you the thickness of the calcium, and we have a very nice study by Fuino et al. Which clearly mentioned that if you have the calcium thickness in the plaque less than 240 microns, you can ablate this with the balloons. You can use cutting balloons, scoring balloons, or normal OP and NC balloons. Now, inducing fractures in calcific lesions is one of the most important things to ensure stent expansion. So you can use balloons if the thickness is less than 240 micron. Let's look at a case example of a thick plate. This was an elderly male who came with the LAD lesion, and when we dilated this, we thought we'd be able to get through, but there was dog boning on the balloon. So we knew we are dealing with a big chunk of calcium in the vessel. We did the OCT, and sure enough, there was a very thick napkin ring calcium. So in view of paucity of time, I'll go to the still images, which shows clearly that there is napkin ring lesion, circumferential 360 degrees. Now, there are certain predictors on OCT which will tell you that you need to use rotablation here, which is if the thickness is more than 670 microns or the calcium arc is more than 227, you need to use a rotablator, and this is what is going to predict the calcium fractures in these patients. So thicker the calcium, more is the need for rotablation. So we did the same. Post rotablation, you can see white thrombus immediately because rota induces dissection. The white platelet plugs will form immediately. You have some broken calcium rings. This is post rota. We did some dilatation, so you had fractured calcium within the vessel, and this is the result post stenting. Now, if you see in the superficial calcific sheet, if we need to optimize, what are the observations which come out of it? The MSA with the superficial calcific sheet is the smallest because I told you this is the one which produces maximum narrowing. And this is probably because these are big chunks of calcium which are there within the vessel, and so they also lead to under expansion of the stent. So if we have to compare the superficial calcific sheet with the calcific nodules, the maximum under expansion happens with the superficial calcific sheet. Well, let's see a case of eruptive nodules. This was a lady diabetic who insisted that she wants only angioplasty. There was a chalky white calcium in the proximal LAD. Wiring it was very, very difficult. With a lot of difficulty, we put an XT wire and used a Nick Nano balloon to create passage for the rota wire, and then took us considerable time to do the rotablation. Post rotablation, we did the OCT. I'll just show you the still images. This showed thick plate of calcium. This showed a circumferential plate with dissection, and they were eruptive nodules. We went ahead and used the IVL. Post IVL, there were some fractured and unfractured nodules which we had noticed, but we also noticed some dissections. There was, I mean, the complete spectrum available. The LCX was normal. We stented with very good results. And when we did the follow-up OCT, we noticed some distal dissection. We noticed some malapposition. As you can see, the white arrow showing that the stents have been lifted. Now, this malapposition was probably linked to the calcium fractures and the nodule, which is lifting the stent up. There was well-opposed stent segment, the proximal part. The proximal part also showed malapposition. So what I'm trying to hint here is that malapposition is fairly common when you do eruptive nodules. They lift the stent struts and you don't have to chase them, and this has been proven in studies that edge dissections are very common with eruptive nodules, and incomplete stent deposition is also very common. You don't have to chase them. You will cause unnecessary stent fractures and cause more damage to the patient. Calcific protrusion, just a case example. RCA, we thought probably it's a thrombus, but when we dilated, it was a very tough thing. It becomes very difficult to differentiate. So this was a protrusive nodule which was there, but it was not kind of compromising the lumen. Had it been doing so, then the only tool available for the treatment of this is orbital atherectomy. You have to either use that or subject the patient to CABG. The last part of my talk is on stent failure in calcific plaque, which is a reality. And the most important element, which everyone here on the panel will agree, is the stent expansion. If you've not achieved the stent expansion, and this is from a very old study published in '93 with the bare metal stent era, which showed clearly that the larger the stent expansion, the better the results or lesser the restenosis. So the long-term outcomes depend mainly on the size which you've achieved and not the type of device. We harp a lot on the type of devices. And if you have, as you can see on this, those who had a CVI score of 4 had considerable under expansion. So this is a reality with the calcific lesions. So this is one case where the images I had shown you earlier. RCA was normal. This patient had ostial left main disease along with diffuse calcification throughout the vessel. We had to use a guide extension catheter to acquire images. He had previously been stented from LAD to the left main. So we saw diffuse extreme degree of calcium in this patient. This was LAD tight stenosis. These are the images which I had shown you. And he had circumferential thick plate calcium. The stent had some ISR. There was calcific left main disease as well. And there was a thrombus which was noted in the left main. Now, having seen all this, we decided that this is the patient who will be served best with CABG. Despite using whatever tools we have to, there will be high chances of him developing stent failure at a later date. Yet another case example of stent failure where we did OCT, and the OCT images show you everything. You have the overlapping stent struts with MLA reduced. You had calcific neoatherosclerosis. And now the white arrows are the calcium which is developed within the stent, and the blue arrow is the calcium which is on the outer side of the stent. The stent was well endothelialized. So what clinical studies have proven that if the calcium angle is greater than 180 degree and the thickness is more than 0.5, you will have greater degree of stent failure. So the neointimal and peristent calcium is very, very important. So if you notice this, be very careful in selecting. So what is my approach to a calcific plaque? If the lesion is crossable, there is absolutely no problem at all. If it is not, we do rod ablation. And after that, imaging plays the central pivotal role in the management of these patients. This tells us about severity and distribution. It helps us select the atherectomy tools, and it helps us in optimal stent expansion, which is the most important thing of ensuring good results. To summarize, the calcific plaques are associated with pure acute and long-term results. It's very important to strategize and optimize the PCI results with calcific plaques. Superficial calcific plate sheets are associated with under-expansion and peri-procedural MI. Eruptive nodules will cause malapposition and edge dissection. Protrusive nodules are generally benign and they do not need to be treated, and if required, they have to be subjected to either orbital atherectomy or CABG. To conclude, in my talk, what I would like to conclude is by saying that intervention of heavily calcified lesions is on the rise, and you need in almost all of these cases multi-adjunctive tools. Selection of an optimal atherectomy tool has to be guided by imaging. So imaging plays a central role in selecting these atherectomy tools, and whatever you might do, whatever tool you might use, you have to ensure optimal stent expansion, and you have to have a watchful eye on complications to ensure good long and short-term results. Thank you so much for your patient hearing. I'll be happy to take the questions.
Thank you, Dr. Chadha. It was a wonderful presentation. You really showed us how the calcium impairs the stent deployment, stent optimization, but you also showed us how imaging helps us to understand the calcium distribution, calcium thickness, and how it impacts the outcomes. And you showed the data clearly to show that less than 240 microns calcium thickness can be well prepared with balloon alone, and between 240 and 670 microns, you can still, you can use either atherectomy or balloon, or beyond 670 is the one which always needs some sort of device, like either a rotational atherectomy or vital atherectomy or laser or even the IVL. So, and the importance of disrupting the continuity of calcium in the calcific lesions and its impact on stent expansion was very well shown in your lecture. I invite others to comment. It was a wonderful presentation, Dr. Chadha, very lucid presentation. Do we have any questions?
Can I ask some question? Sorry.
Yeah, Fisher.
Hello, Dr. Chadha. So, if I may ask you, I'm sure with your vast experience, you would not have had a scenario that often when the preparation was not sufficient before stent deployment. But if at all there was a scenario where you have put in a stent and you feel the lesion is not yielding no matter what you do. So the so-called stent ablation versus IVL, what would be your choice?
So, I mean, IVL is a recent addition in the armamentarium. And I have certainly had the opportunity of using IVL, not in very bad cases. I mean, what I think you are trying to ask is that I've deployed the stent, and now I see the stent in the middle or in the proximal part is absolutely underexpanded and is not yielding. Is that what you are wanting to ask? Whether what do I do in such cases? So I've had the opportunity of using IVL in these situations, and IVL followed by high pressure balloon dilatation works very well. That is, probably you have a single layer of metal, IVL works well, but if you have multi-layers of metal there, then the efficacy considerably comes down of the IVL. Now, using an atherectomy device like rotablation, which you said, I am not too sure, because you will have to not only ablate the metal and then reach the calcium. I don't know whether it's going to serve the purpose or not. So I don't think that has a role to play there. But yes, IVL I've had the opportunity of using in one or two cases, and these were not so severely underexpanded. But we thought that we had some pulses left, so we used them post-stent deployment and followed by high pressure dilatation, and they yielded very good results.
Thank you. Thank you.
Can I ask one question? Can I ask one question, please?
Please,
Go ahead, Dr. Pillai.
Yeah. See, Dr. Chadha, your presentation was very lucid and very educative. Now, when we use a high pressure balloon like OPN or an IVL, will it not disturb the stent anatomy? What happens to the coverings of the polymer? And what happens to drugs? Do we have any follow-up studies to enlighten us?
I am not aware of follow-up studies, sir. But what I can tell you is that at this stage, when you leave an underexpanded stent, you're more worried about acute stent thrombosis and its consequences. So, I mean, if I leave an underexpanded stent and the patient comes back in middle of the night, and if he happens to go to some other hospital where the physician is not aware as to what has been done, I mean, it will be nightmarish. So with that in mind, even if there is certainly what you're saying is very pertinent, that there will be polymer damage, there might be strut fractures, which are unpredictable at such high pressure dilatation. So which brings us back to the point that one needs to prepare the bed well before you think in terms of implanting a stent. If you're not too sure that you prepared the bed not too well, it is always better to come back with better gadgets and do a neat job than to rush in and stent that given segment.
Yeah, why I asked, Dr. Chadha, why I asked you this question is, recently I had a patient with 3 layers of stent overlapping, and I used IVL, delivered 80 pulses at one site and 40 and 40 on the proximal LAD, ostial LAD and the left main. When I stented it, that 80 pulse delivered site did not open adequately. Then I have to use an OPN at 53 pressure. Then it give away, and then the final OCT is very good, but I don't know what happens to this patient.
So that was my opening remark, sir. I had mentioned that in multi-layer stents, IVL has got absolutely no role because it hardly gets any space for the sonic waves to get in and to deliver the desired high pressure ablation.
BC, sir.
Thank you so much. Thank you.
Thank you.
Yeah,
Thank you. It was a very
thank you, Dr. Chadha. It was a wonderful presentation, Dr. Chadha. I call upon Dr. Pratap Kumar, a senior interventional cardiologist from Kerala, on his talk to present his talk on tips to avoid complications during PCI calcified coronary arteries. Pratap.
Yeah. Thank you, BC, and all the chairpersons there. And once again, I thank Dr. Deepak to give me a chance to talk about this topic. A cardiologist with a calcified lesion is a real challenge. I think for the last few talks, you would have heard that a lot of calcium challenges created for us. Basically, because the severely calcified lesion has a worse clinical outcome compared to those without a severe calcium. You can understand the 1-year rate of death, cardiac death, definite stent thrombosis, ischemic TLR and TVR are significantly increased with moderate or severe calcium. Calcium can cause wire uncrossable balloon uncrossable, balloon undilatable, and stent under expansion. And that can lead on to a lot of MACE. So this is a case of a 71-year-old female with a diffuse disease. You can have an RCA is already done, stenting. You can see a tortuous anatomy here. We just passed the IVUS catheter, could not cross a distance. And the wire could not cross the distal lesion. We took a 1.5 into 15 Maverick and a rota ablation at 180,000 RPM. Then we did a calcium break seen by rota, definitely seen, but the wire is only seen in the diagonal part. And you can see we did a dilatation with a 2.5 into 12 Maverick balloon. Finally, we got a dilatation in the proximal part. Ostial LAD has no non-significant plaque and vessel diameter is nearly 4. We took actually one more wire key we kept in the S1 and stent kept from the proximal LAD. We put a 2.5 into 26 stent already put there. The distal LAD was actually wire crossed with the help only with the cross crusade. You can understand that the crusade only helped us to take the wire down. Otherwise, the wire was not going. It is a real tortuous anatomy. So subsequently the wire gone down. Then we actually took a stent could be taken only with the help of a guide liner. You can understand that crusade, guide liner, all used for taking a calcified lesion. Then only we could finish the case. And this was the final result created in this case. And we did a final result with an IVUS showing an excellent dilatation. Actually, in the middle part, distal stent edge, there is a nearly 4.1, we got the area. So access and catheters, femoral access can provide superior support. You have to use a larger guide catheters with a supportive shape, especially for AL1 for RC and EBU for the left main system. You can use microcatheters and hydrophilic wires, especially cyan black, to take the wire down in calcified lesion. The wire fails to go through the lesion are suboptimal guide wire shape, tortuosity, or a poor guide support. What can go wrong during a wiring? It can create a coronal dissection, and that is the most important thing. In uncrossable lesions, you can use a small balloon wedge technique, balloon assisted microdissection, and increased support, microcatheter wire exchange, atherectomy. What is actually balloon wedge technique? You can use a low cross profile and a long length. The balloon profile is highest at the marker. It can maintain the forward pressure. The granuloplasty of the balloon assisted microdissection using a small balloon, inflate at high pressure until it ruptures, but use only small balloon. When the balloon ruptures, suction should be applied. The side branch anchoring as well as the coaxial anchoring can be done to take the balloon down in a calcified lesion. And the plaque modification microcatheters are 2 Taunus and turnpike load. Turnpike gold is not available. The only difference actually advancing with the counterclockwise at Taunus, and turnpike is actually using advance with the clockwise direction. Buddy wire is another way, increases the guide wire support and strengthen the target vessel. Support guide wires are usually Ironman and Grand Slam we use regularly. Undilatable lesion will be like this. You can understand this in another case where we have done a PCI to RCA. We thought circumflex lesion is a very simple lesion. You can see a lesion there, but we tried with a 2.5 balloon, could not cross, tried 1.5, crossed but not opened up. We used a guide liner to take, it did not help. Used to take a 2.5 balloon, nothing is going down. We actually tried a rota ablation because of the 3 curvature. We could not take even the rota down because I suspected a guide wire bias and create a perforation. Multiple wires, anchoring, side branch, OPN, cutting balloon, all tried except IVL. That was not with us. So we failed this case. So the NC balloon, ultra high pressure balloon, cutting balloon, rotational atherectomy, IVL, excimer laser. Which one to select? Usually you have to do an imaging. Imaging will give a clue for these things, and there are a lot of studies published in the last study, trial also, last talk also for that. OPN balloon problems, deliverability is actually bulky, rare complication, balloon rupture and shaft rupture. Tips to remember in OPN NC, use an extra support wire, 0.5 millimeter lesser diameter to be used for a pre-dilatation, post-dilatation 1:1, slow increment of pressure is to be used. IVL, it position across the segment, calcified segment. You can IVL should be 1:1 size, perform de-airing, initial inflation is 4 atmosphere, set of 10 pulses delivered, then you have to further inflation 6 atmosphere to compress the fractured plaque. IVL complication, dissection and perforation can be caused by the balloon rupture. Actually, you can cause even VF in some cases. Cutting balloon, larger crossing profile, inherent rigidity, difficulty in crossing, but it is a wonderful device. Only thing is avoid high pressure inflation. You can avoid a coronary perforation. Basically when an avoid across the stent, otherwise you have to inadvertent extraction of the previously deployed stent possible, gradual pull, otherwise it can create problem in the fracture. This is a case of a class 3 angina. PTC had done 11 years back. This was the angiogram. This was an I was done, and to understand that, we decided there was a calcium, but actually we thought it can be easily tackled. We used a 2.75 into balloon and a 3 into 10 flex tom. We did an IVUS to understand, and 310 at very high pressure because the IVUS did not show an opening of the vessel. But when we opened up a IVL cutting balloon and followed by a 4.4 into 12 millimeter balloon, patient got severe chest pain. What was the cause of the severe chest pain? This was the reason. We can see a staining in the circumflex area. This was actually that happened. What is to be done here? We used a 3.5 into 16 graft master because it is little away from the ostium of the circumflex. We kept there, and post dilatation produced an excellent result, and the patient did very well. But this is a problem can happen. Scoring balloon, again, focus force, increased profile, complication can be failure of balloon. Basically, the nitinol guide wire can be caught on the calcium spicule. Inflation, deflation, advancing and rotational movement, buddy balloon technique, and deep intubation, you can retrieve the scoring balloon. That rotational atherectomy is an operator and a team dependent procedure. Basically, to understand that, the rationale is to modify the calcified plaque, not to debulk the procedure. This we can show a case actually. This was an angiogram, shows significant disease, circumflex as well as LAD ostium, and the PTC had done, tried. You can see a significant calcium everywhere. We tried a filter FC wire. You can see the wire actually did not go down. We did a fine cross, rota wire actually. We took a fine cross with the help of a rota, we went down. We tried a rota 1.5. You can see that rota 1.5 is actually not able to travel. We tried, we did not take a rota 1.5, did not travel. We actually downsized the rota to 1.25. We went up to high pressure, and the high pressure actually crossed the proximal part, not distally. We actually, then we did a 1.5 in 10 balloon dilatation. Then again, we tried a 1.5 rota, 1.25, then 1.5. Then we did a balloon dilatation, 1.5 balloon, and dilated. Finally, what we have done is actually we did a rota 1.5 bar. The bar kept in the proximal part like this. After keeping the bar in the proximal part, we tried again to go down. We tried in the distal part again 1.25 bar. Now 1.25, then 1.5, and again they came back to 1.25, and we did a that actually you can see the rota bar is almost at the wire. We don't want to go to that part to create a problem there. Then 1.5 millimeter balloon. You can see that the distal vessel is still not opened up. So we tried the wire is actually, we extend the wire to filter XT, then wire crossed, then we could do 1.25, 1.5 millimeter dilatation, multiple dilatation, tight lesion, circumflex. Already there was a dissection created. We could not do anything. We did a 3 and 3.5, 10 balloon, multiple balloon dilatation. Finally, we ended up in the 38 stent in the LAD and a 3 into 8 LMCA to circumflex. And then we did a 4 into 18 stent into LMCA to circumflex, and post dilatation done. Finally, we did a post dilatation. Distal we tried to open, we failed to open. We did a 4.5 into 8 and 3 into 12, and we got a multiple balloon dilatation, same balloon at high pressure. Then this was the final result we got. This is actually the problem of the calcium can create. So be less aggressive. Aggressive strategy is actually ratio should be more than 0.7, offers no advantage over the more routine burring. The keep atherectomy duration less than 15 seconds, and should be a pause between runs, ideally between nearly 30 seconds. Don't do the occlusion through the guide wire will not pass high risk of perforation. Lesion to venous graft, not routinely. Avoid small branches, eliminate loops and kinks, primary wiring with the rotation. Dissection is not an absolute contraindication. This is important. Expect complications, severe LV dysfunction, severe multivessel, especially unprotected LMCA, lesion length more than 25 millimeters, lesion angulation more than 25. So rota in aorta ostial disease, ensure the coaxial alignment, avoid wire loops. Only rota wires should be present so as to avoid cutting wires risk. There are some situations where you can use a double wire rotational atherectomy, keeping a guideliner in one side branch and the wire in the other vessel. You can do that, but I did not do that. The guide extension assisted rota in bifurcation and tortuous anatomy is helping. Wire rota in tortuous and vessels, actually wire bias is the problem. Calcified lesion in the inner plaque can create problem. Rota in a calcified CTO, we can use actually cases in which the balloon or microcatheter will not cross the lesion to permit the wire exchange. Try to avoid slow flow where use optimal antiplatelet anticoagulant, continuous flush cocktail, as well as optimal burring technique. What are the causes of rota coronary perforation? Tip trauma, inappropriately sized wire, burst, transection, and wire bias. Don't try to finish the atherectomy with a single burr, and burr could not travel across the guide wire. Rota wire fracture also can cause problems. Burr entrapment. This is actually a person. One of my friend tried angioplasty 2 weeks back. They tried balloon and no balloon was dilated. I easily passed the rota wire and 1.5 bar moved down, not coming down. So it was actually a stuck bar. Stuck bar actually the problem. I was thinking that you can see that the wire going up, even the catheter gone down, the stuck bar is sitting there. What is the next choice? Manual extraction, one more wire and balloon dilatation, slit open and keep it there and surgical extraction. Manual extraction, rota wire moved, catheter came out, severe chest pain, checked LMCA, what next? What we did, one more wire and balloon dilatation. 7 French cannot accommodate additional catheter, but you can see that this actually, I could take the wire down. You can see that catheter just gone down and taken it. Finally, we could actually slit open the rota catheter and we could take it out, then filter FC. Then it was simple 3 into 12 millimeter balloon, but it was a dangerous situation. We put 2 stents, one proximal, distal, and final result is like this. We produce a good result in this case. So the conclusion was actually presence of mind was rota blocked under stent. This is a patient where we tried a balloon dilatation and a stent there. You can see a balloon. We thought it's a simple lesion. We put a stent there, but it is unopened. What we did is actually nothing was working. We thought we will do a rota. Actually, rota burr actually kept just before the lesion. We could open it. Finally, we could open and finally produced an excellent result by the stent ablation. But actually, I can tell you that this is another case where we tried a stent ablation, but we damaged the stent. Open NC, we thought we will do a stent ablation. Then this is actually the problem created. Proximal stent got damaged. That is one problem with that. High pressure balloon dilatation. Finally, also we got one more stent down and produced result. Need for temporary pacemaker not routinely needed. Complication encountered during calcification. Severe calcification, atherectomy on a neck wire. Balloon rupture, actually suction should be immediately done. Balloon fails to deflate. You have a lot of things. Coronary perforation is the most important complication can happen. Universal algorithm of the coronary perforation and type specific treatment to be done. And this is the thing. And we have done a lot of cases and I'm not going into the details. And this is actually a rota is to be used in most of the cases. And thank you very much.
Thank you, Dr. Pratap, for taking us through the complications and prevention tips and tricks to prevent the complications during treatment of the calcific coronary artery disease. If there are any comments from my co-panelists, I invite.
Hi, Pratap sir. I have one question. In your practice, how do you tackle isolated ostial circumflex stenosis with calcium?
We actually do, we ideally, Shafiq, we have to do an imaging and understand how the calcium is actually. Concentric calcium, you have no tensions. If you have an eccentric calcium, the wire bias create problems. So you should actually do a balloon dilatation. If you can get away with the cutting balloon, that is the ideal choice. If it is not there, you have to do a burring properly and with an angulation. Otherwise, the burring should be done in one side. You can create a dissection on the other side. Where the only situation, even though people tell you can use an extra support wire, I always use a floppy wire in these cases. Dangerous.
Thank you, Dr. Pratap. We are running short of time and there is a live case waiting from Mount Sinai. We had a good first session. I thank all the speakers who did a wonderful job and all my co-panelists. I hand over the mic to Dr. Deepak Davidson. You can take us through the second session. Thank you, Deepak. Thanks all of you.
Thank you all.
Let me take this opportunity to thank all the speakers, moderators, as well as the expert panel. Now we move on to the live case session from Mount Sinai Hospital, New York. For this session, we have expert panel, Dr. Jespal Arneja, he's from Nagpur. We have Dr. YVC Reddy, who is from Apollo Hospital, Chennai. Dr. Mohammed Mustafa, Chairman of Metromed Hospital, and Dr. Praveen GK, who is the Chief Interventional Cardiologist at SCT Hospital, Trivandrum. Now we also have moderators, Dr. Pratap Kumar and Professor Natarajan. Professor Natarajan, he is head of the Department of Cardiology at Amrita Hospital. Let me request Dr. Natarajan as well as Dr. Pratap Kumar to moderate this session, and we move on to the next session. Thank you so much. Natarajan sir, please.
I'm here, and I'm along with you.
Pratap, is the case, are we online with the case?
No,
Yes,
now
sir.
we are going to.
All right.
Yeah, please.
Good morning. Yeah.
Yeah, you can hear it.
Good morning.
Yeah, good evening here. Yeah.
Good morning.
And you can see us, hear us.
Yes.
Team
Very
from
well.
Mount Sinai, and the thanks for giving this opportunity to us to put live case. And we have been preview to all the excellent discussion on the calcific lesion, which is the theme of today, Conquering Coronaries. I really like the title. It's a fantastic title of the today's your workshop and conference. And thanks for giving the opportunity with Abbott Pharmaceutical. And I know there is a very esteemed moderator and panelist which have joined here. I want to just show this brief presentation, and then we take you to the case, because we have a very limited time till 12 o'clock, which will be your 9:30, because that time Greg Stone is going to deliver a lecture from 12 to 12:30, from 9:30 to 10, and after that needed, we can come back to and show the final. So with that note, this is our cath lab team. You saw every one of them, basically two of myself and Dr. Keeney on my left side for this case number 1, which is a 69-year-old patient has a chronic CAD with prior PCIs. Patient did have a COVID last year, risk factor there. And as you see, SAQ7. So knowing that many of these patients don't have angina, they just have a discomfort and limitation of daily activity, SAQ7, which is a very quick, and we have published that, the kind of correlate with your angina class. So anything close to 100 is good, angina class 0 to 1. And of course, once you go to the 20, less than 20, that is your angina class usually like 4. So this patient presented to outside hospital with class 3 angina and positive stress test for multivessel ischemia. Patient had a cath which revealed left main and 2 vessel disease with syntax score of 32, near normal EF, and no valve disease on a very good medical therapy. And of course, after the CA cath, which we are going to show, cabbage was recommended. But patient with a syntax score of 24, STS of 1.4, patient opted for PCI and has come here for OCT guided PCI of left main. So this is a LV. We can go to the angiogram, actually appropriateness. Let's go to the appropriateness before, sorry. Go back to the our picture again, slide again, please. Before, yeah. So any of these complex cases, we always present our appropriateness use criteria. And this particular patient, heart team approach, syntax score, STS score, actually anything more than 4 is bad. So this patient is a good case otherwise for cabbage, but ultimately it is a patient who decides. And if you put this patient into this left main coronary stenosis of criteria, will be red, but after heart team discussion, in my opinion, become A, appropriate, because that's what the patient wants. The patient knows plus minus of both the techniques and so on and so forth. So with that note, good LV, we go back to the angiogram, and this is a patient has a stent in the right coronary, which have been fine, completely open, and had a stent in circumflex in 2013. And here is the problem. You see the stent in the circ are okay, but particularly the little bit disease in the OM further down after the stent, but culprit is your distal left main. We can go back to show that angulated, very tight lesion of the 80% left main, and then LED diagonal, very calcific, and which is the here. So calcium angiographically, of course, is the severe calcium. That is what we say. You can do any imaging, but once you see a tram track, the entire vessel goes, it is a severe calcium, and many times our imaging catheters do not go. And that is exactly, we said, knowing that this is a theme of the imaging and calcific, we say we try OCT. And now tell us what you found.
Yeah, so if you see here, I mean, you have to be very cautious. Distal left main, I would say 80%. And even if you want to do imaging with OCT, when you're doing OCT, you have to make sure that when you are flushing the contrast, there is the contrast will disappear. If you think there is no flow in the coronary artery with a catheter sitting there, you should not proceed with OCT. You will give a risk of VFib in a patient. So if you see the catheter would not go any further, we did not push it. And we were able to do the OCT, which you can show the OCT by the side. Now, the imaging catheter did not go further, essentially says it is not probably 4 quadrant calcium with significant stenosis. So this is proximal LAD with left main. In the left main, we are seeing at least 3 quadrant of calcium there.
Look at that.
Yes.
Severe calcium. And of course, OCT not only can tell you about the degree of calcium, the depth of calcium. I mean, length, depth, all that can be obtained by the OCT. So with that note, knowing that our plan was to do rotational atherectomy anyway, initially we were thinking whether use a 1.75 or 1.5, but based on the catheter movement, we thought we'd go with a 1.5 bar, and maybe you can have your discussion while we are ready to do a rotablation here. Using a RotaPro, we have this the new RotaWire nowadays called RotaWire Direct, which is both floppy as well as the extra floppy and
extra support.
Rota Drive. Sorry, the name is Rota Drive. A little more one-to-one torque, but to me, it has become a little more flexible. I mean, it's not given you that much power. Therefore, many times you may need to use extra support, but this is a Rota Drive. But we are ready now with a 1.5 bar, with knowing that left main 1.5 may be small, but that's okay. Our goal is, remember nowadays, we are not debulking. We are just changing the plaque. So we are here now. That's good. That's fine. I think so if anytime there is a problem, you can always dynaglide if necessary, but push and pull. Wire is in very good position. Go with the 3 steps, which Anu is going to do.
So if you see here your knob, your black knob, you have to go backward, forward. So you're removing the tension between the Teflon sheath and the bar right there. And then at the Y connector, move backward, forward, anything between the bar and the wire. So after that, you are on Dyna, which is just about 65,000 RPM. Just press the knob. So on the Dyna, it just moves slowly. So if you don't do these 3 steps, the likelihood of bar jumping is very high. We should not be allowed. So we know we are in the ostium of the left main, almost in the body of the left main. So here we start burring, and we have to make sure the blood pressure. You can show the hemodynamics by the side, so they can see the hemodynamics as we're doing the bar.
What is the guide?
So we're going to start burring.
It's a VL. Yeah, we use the Mark guide of Boston Scientific. It's a VL 3.5. Yeah.
Now, 1.5 bar may be too small for the left main, but doesn't matter. This bar we selected for the LED. So, okay.
What is the RPM used here?
Yeah, actually, usually 150. What happened is the machine comes with a set 150. The previous case we did was a very tough one. We went to 170 to remain 170. So when we started, so we didn't want to change it. But about usual, our strategy is RPM about 150, 155. If it does not cross, you can always go to 170, 180. So right now it's 165. Yeah.
So with my left hand, you see here, I'm just holding at the guide to make sure the guide is well stabilized and slow pecking motion.
And it's a 6 French guide.
But the calcium was more in the LMCA part or in the LED part?
Both places.
Both places.
But
yeah, LED probably more than 3 quadrants.
Yeah. Distal left main is also 3 quadrants.
Yeah, distal left main 3 quadrant everywhere.
Yeah, I mean, clearly you saw that I was, the OCT catheter didn't even go further. Yeah.
Can you bring it this closer?
Good.
Good.
Yep.
So I'm just going to do a polishing run.
Okay, we're ready.
I think we're done. We're coming out. Again, back on Dyna. Let me run through wire.
What is your principle? You will do an imaging again to understand whether to go ahead with the higher burr or the other technology called cutting balloon or IVL, whichever the choice to be done, or the preparation of the lesion is by OPN or cutting balloon. Or
yeah, so very good point. Very good point. And we always say that knowing that we don't use the aggressive burring techniques now with a burr to artery ratio barely 0.3 to 0.5. So what we'll do is we'll leave the rotor wire on the side. We put your work horse wire and then dilate with a simple balloon, because you don't want to increase the cost if not necessary. So here we have a few choices. One, we go with a 2.530 high pressure NC emerge.
3.0, no? 3.0.
3.0.
It's a huge vessel.
2.5 now. So we have the 2.5 ready. And then if does not open, you can have two choices then. Either use a IVL or a cutting balloon or just go with the bigger bar. So we have because we went on 1.5. Your 6 French can take 1.75 bar also. So this is where will be our goal. But in my opinion, this one should open. So once you are done, because it doesn't have to be that you have debulked, really remove the plaque. What you do is you cause those micro, all the techniques have shown that you call a micro fracture, whether it's an IVL or it's a, actually Rota is probably the only device which shave the, like in the nodular calcium is going to shave it. And then subsequently what happens, the calcium becomes thin, your subsequent balloon will be able to, yeah, that's fine. Yeah, subsequent balloon, yeah, here. So this is the run through wire. And now we are going with a 2.530 balloon in this calcific. Now, the modification at the level of the left main will be a little different. Definitely, I would put a wire into the circumflex because that's where the plaque will be more. And there we use a 3.0 or 3.0, I would say, our Wolverine cutting balloon.
Sir, in this case, actually, in this case, when you have a very tight left main lesion, would you, consider pre-dilating that lesion before, so that it will become a little more easier for you?
Yeah. So, question is very good point. So, key is that once you have very tight lesion and you are able to get your balloon further, your rota, that will open up to 1.5 lumen. Now, see this at 18 atmosphere, our this mid LED lesion has opened up very nicely. And we are using the rota as a modified cutting balloon, one blade kind of that rota wire. No, but we don't want to open the, you will not extend the proximal LED. You don't want to do the balloon there.
There was a plaque shift possible in the distal LMCA. So ideally, when the vessel is opened up, keep a wire into the LED, into the circumflex, then only you do that.
That's fine. Good. Okay, so LED has opened nicely. We can remove the rotor wire. And let's go to the RAO caudal view and work on the left main to circumflex. That's where the money is. Money is in that left main to circumflex lesion because if we go to the distal left main, can we see on the OCT?
Why don't you stand here? Under the
Which
left
one?
main.
Oh, you mean stent of the LED first?
Yeah.
Okay. Let's stent the LED and then we come here. That's fine too. Okay. So we'll take a Zions 3033.
From where? Below the diag?
Yeah, doesn't matter. Yeah.
Below the diag?
Yeah, below the diag. Yep. We have the latest Zions Sky Point. 3033 will be good enough.
Okay.
Yeah. 3033.
It was a 30 balloon service. It was a 33 stand.
Yeah.
But how did you measure the size of the stent now by the, we could not see by imaging the diameter, you know.
Yeah, so I mean, very good point. So key is, we call it a eyeball OCT based on the, yeah, you decide now, I mean, to be more precise, yes, because remember in the DES, you are a little more in the here. This was our original angiogram. So based on that, you will say, will be because we are avoiding the diagonal. There is a moderate disease in the diagonal. After the diagonal, till that about 3 o'clock, about 33 millimeters. So that's where we have.
That's the 3O SL LED.
Yeah. 3O. So we have 3O 33.
The length is okay, but the diameter, how did you choose? That's what I'm asking.
No, the diameter is again based on, eyeball.
Yeah, same.
Eyeball QCA.
No, but
I'm understanding. Yeah. You can,
I would say,
when you're doing the OCT, can you give a diameter?
Yeah, so it's a media to media is around 3.5 and then mid LED.
We don't go media to media. No.
Yeah, but actually the concentric calcified lesion. So I think the 3.0 is
show the
okay.
OCT the same.
OCT. Show the OCT.
Yeah,
good. Okay, good.
Yeah, this is the just after the diagonal. So I'll show the diameter of the media to media is like 3.5, but I think the lumen is like auto measurement is like 2.2 or something. So I think the concentric plaque, so 3.0 is I think okay.
Yeah.
So we have 3O. Yeah, we have 3O. We have 3O 33 at 16 atmosphere. The new Zions
Sky Point.
Zions Sky Point, which is the stent remain the same. It is a delivery catheter, which has changed, and we'll take the picture now after this, and then we go to the left main.
Okay.
Yeah, good.
Now let's
so
make
that's
sure.
where I would say.
Good.
Yeah. Yep. That you really need to have imaging. So here we are good. Give us the.
That's a step down. Yeah.
We can do those things later, but let's go to the circ now. As you see, this will be a little tricky because there is a lesion and then there is a tight of the circumflex. If we can go back to our earlier picture.
Okay, let me show. Wait.
Yeah. Here.
Okay,
now
good.
go. This view. We'll go back to the view. LAO4, caudal 35.
The calcium was eccentrically seen in the imaging. We did not see the LMCA calcium.
Go back to the LMCA calcium, show it to them.
Okay. Tell them that one view could be all time show the OCT imaging. They should continue that.
So now I'm showing the this is the circ from the 2 o'clock. So I go clocks now. So this is just a distal left main. From 12 o'clock to the 7 o'clock, it's all calcium. So distal left main has the 3 quadrants.
So we have 3 quadrant calcium.
Yeah, distal left main.
Okay, that's where now we are. So clearly the disease is into the circ and the old stent. Actually, they were also the Zions stent which remained fine in the circumflex, which were done outside. Patient has come to us only first time because he was asked to, after the angiogram, he was referred for cabbage, but patient did not want to go for cabbage, and that's how his private cardio interventionist actually.
The circ.
Yeah.
Dr.
To the circ.
Would burring from left main to circumflex also add more value to the burring that you did from left main to LED?
Yeah.
I think that is not essential. If you see, because it is just a short area, angiographically no calcium, nor we can see any.
No, there is a calcium. The LMCA, you have a 3 quadrant calcium. We did not understand the ostial part of the circumflex. Without that image, how can we tell that there is no calcium in the ostial circumflex?
Angiographically one, and the second is If we cannot get, so we have everything ready, and we can change accordingly. But distal left main, we would do with a 1.5, which I said we can always go with a 1.75. Hold it there. Good. Yeah. The chances are because of the angulated. Yeah. If it is essential, then you have to do it. But based on the way it appears, in my opinion, again, the calcium. Remember, we have all published that once angiography is good. But of course, with the severe calcium, angiography is quite well. Mild to moderate calcium. See, there is a stent there, and let's try to go. Otherwise, get high pressure.
No, the stent. You remember, it may not allow us to get into the.
So we need high pressure. What do you want to do?
I think we go with the high pressure.
Okay, 3 or 12 high pressure. Yeah. So
it may be hitting. There is a stent in the proximal circ.
Yeah. And we don't have that angiogram of 2013. That's the time stent was placed.
Okay. You can do it. Went a little bit more.
But the stent could be seen up to the ostium, or how far away from the ostium?
No, look a few millimeters away.
Okay.
The true ostium is not covered.
Yeah, true ostium is not covered.
No, you went up. No?
What balloon is this?
This is a flexed, the Wolverine.
Yeah, good.
Okay, now it went forward. Yeah.
See, we say that Wolverine, once your nose is into the lesion, you can just do a little cut. So basically, you are making your way through, plowing through. And so pull back.
3 or 2.
It's a trio. It's a trio. Yeah.
Now you see how it made a turn. Yeah.
It's a 306.
36. Okay.
It's a trio.
So millimeter by millimeter, we did the cutting, and now let's do a cine. See, it's a good expansion. If we had not seen a good expansion, I mean, we all based this on angiographic calcium, then yes, if we had thought that we needed it, we would have gone.
And question comes in, when do you want to do OCT? Want to do it after the deployment or before the deployment?
After.
That's remain your question. And I would just say that so far, remember the data of the iLumen 3. What was the data of the iLumen 3? The primary endpoint was minimum stent diameter, and minimum stent diameter with angiography as well as with the OCT was similar, not different. Why? Because our eyes are very much tuned. Now you want to go into that OM little further with this? See if you can go. Remember OM, this further down, little restenosis. Yeah. So key is our eyes are quite well trained, and those cases were severely calcified were not included. So that's a different story. So clearly in the severe cases, you need to decide what is the best way. So we say borderline cases, you definitely, let me go up here. It's a restenosis there, partial, little bit restenosis there.
Not that way.
Yeah, that's same.
So you have
We'll go a
taken
little
the same
further.
Wolverine balloon down?
Same further down into that OM, because there is a moderate disease there.
Actually, what is the plan for this case? You are doing a DK crest, or you are putting a stent from the circumflex, a short stent, or LM to LAD one stent, and what is the plan?
Tell us what you want to do, AK. Yeah.
No, I would want to just stent across.
Huh? Yeah. So stand, but from the left main to circ.
Yeah, left. No. Oh, you want left main?
Yeah, left main to circ. Yes, because disease in the ostial LAD, as you saw, was not there.
There.
Because there is actually a small segment of ostial circumflex is not covered by a previous stent, and there is a lesion there. So we have to cover that.
Yeah, that's correct. So our goal is from distal left main to the circumflex. So single stent strategy, because ostial is okay. Now question is, what's against the two stents?
No.
Because ostial LAD seems to be okay. So we do a stent in the left main. Take a picture now. Again. Good. Fine. Lengthwise. 38.
Lady proximal part, do you think it is okay, and you can just leave without a stent there after putting?
No, I think we have to. No, because there was a tight lesion. Get a 3.538. You put a wire into the main vessel. Further. Yeah. So we are going to put a long stent into that OM because there was a moderate disease. That's okay. Leave it then. It's still curled up. Yeah, good. Leave it. Okay.
Why you want to stent like that?
Which one?
That
one
length.
second. Wait. Tell us what do you want to do? Stent should be from the left main to the circ because there is ostial circ involvement. So short stent or long stent? That's the point.
Short stent.
Okay. Then 3.518.
Yeah.
Okay. 3.518.
Sir,
Yeah.
actually,
So key is
I just wanted to understand that you are going to put a 3.5 into 18 from LMCA to circumflex. What is your
yes.
plan for
That's
the LED osteoproximal part?
yeah. The question is, do we do a and then followed by kissing in this case because of we had to go worry about the diagonal. Usually, you can avoid putting the kissing balloon, and that was part of the meeting last week. And also, whether do you routinely do a kissing balloon if there is no disease of the second branch? In this case, stent crossover, one stent going to the circ because of the lesion in the circ, and LED seems to have no disease. Now, once it is, in this case, because there is additional disease, we put a stent in the LED. There is a diagonal disease which may take a problem later. So we'll definitely do a kissing balloon after single stent.
So you are planning for a provisional stenting
What's
and
the
then
proximal
Provisional
imaging of the
stenting,
imaging?
yes.
then will you do an imaging after the stenting to the
Yes,
circumflex?
definitely. Yes, absolutely. Yes.
Imaging to the LED.
Yep. Yes. After opening, we do it. Yes. Yeah. Clearly, we need to know what is happening with the ostial. We need a high pressure balloon. Or what? Why it is not going now?
Maybe left main we didn't open enough. I was not planning to stent the circ.
No. So, yeah. So
Get us high pressure balloon to get into the circ.
I'm sorry. What is the question?
Maybe imaging at this point before you actually put in a stent, so that would be helpful. For two reasons: you would know exactly what's happening in the calcium, in the left main, distal left main, and once you put a stent, your options of dealing with the calcium become fairly limited.
Okay. So we are just dilating there a little bit. Let's ready we already have OCT. Let's do the OCT run. Yes.
No. Just dilate. We'll dilate and stent will go.
But we can do OCT before putting it. That's what.
Angiographically, the osteoproximal LED looks, has got a significant disease. I don't know what about the OCT. Probably I think we may have to do an OCT to see that.
If in that case, then we do a DK crash because we put a 6 French guide here.
Done. As I said in the beginning, I said 7 French and okay.
It's still going now. Good.
Go up here, high pressure.
What pressures have you gone?
It's 18. 18. It's a 3012.
Seems to have opened up fairly well.
Yeah, it definitely has opened up. But I think it's reasonable now to do here.
Go up here again.
Yeah. Okay. No, a little further. Good. Okay. Good. All right. So now
get the stent.
No, but do the OCT first.
No, what are we doing?
Yes, they wanted. There is strong feeling that OCT will help here to understand the plaque. Or you want to just put a stent first?
Just put the stent.
Okay. So we're going to put back that stent, which did not go a little earlier, and then we do the OCT.
Even suppose we did the OCT before we did the PTCA here, right?
Yeah.
And we saw that there is calcium. What is the next step?
We'll dilate right further because right now the rotational atherectomy has no role at present. Question is, you can do a IVL, that's one, or use a bigger cutting balloon.
You already dilated and kept a very nicely opened up osteoproximal part.
Exactly.
I think
that is correct.
now there is no choice of doing another preparation of the lesion. The only thing is there will be a tough situation to take the stent down. Means you have to use a guideline or a guidezilla down to take the stent.
Yeah, no, will go. It will go. So
no, the reason it is probably not going. If you see here, you see. Let me go on cine. It's sitting against the previous stent, and then you just have to advance a little bit. If there was no stent, this would have gone. Even with the cutting balloon, we had a lot of problem. Or you want to stay like that, right?
Yeah.
Okay. Now it's a run-through wire in the LED.
Yeah, that's fine. That's okay. Okay, that's where our idea was. Good. Okay, we're going up now. So just to say, in this case, we decided to go from left main to circ because there was an ostial uncovered circumflex disease. The stent was there, but further down with a moderate stenosis. But basically, because there was a tight lesion at the ostial circuit, LAD does have disease, about 30-50%, but see the ostium has an 80%. Actually, outside, the interventionalists read 90% ostial circuit, they read left main only 50%. But to me, if left main is actually much more than 50%. Okay.
But the question is that what are you going to do the prox LAD?
Yeah.
Now, prox LAD, if we are going to now, the only issue is the diagonal has significant calcium and is a large diagonal. At this time, we don't want to do anything. That's the reason the plan is stand from left main to circ. If everything looks okay, leave prox LAD alone, thinking that in the future, we will have access to prox LAD and diagonal.
Take a picture now.
Or to take the stent start.
Good. Ready?
Now get us a 408.
Well, let's do the IVUS first. OCT, I mean. Let's do the OCT. Yeah.
But eyeball, actually, the angiogram picture, I think there is a significant osteoproximal disease in LAD.
I would also agree.
This wire actually has curled up, as seen is good and bad days.
Okay, now we are good.
Now good. Okay. Yes.
I have to take out the run through from behind the stent start. Huh?
You can take the LED wire out right now, and let's do the good. Yeah, do it now. We are doing the OCT now. And remember
Now,
what happened.
hold on. They want OCT from left main to LAD. Why are we doing into the circ?
Okay, then we have to open the ostium a little bit.
Yeah.
Good. So you want to rewire right now?
Let's rewire, but
ideally, you also want an LED to LMC run rather than circuit.
Yeah. No, that is what we are planning now. Yes. Exactly that is what we are planning.
But before that, let's spot, no?
Okay. 408.
Yeah, 408. I'm going to rewire into the LED. Rewire into the LED, and then we do the pot of the left main, so we don't have to do multiple runs imaging to make sure there's a full optimization. And then we decide what to do. Hold on.
Oh.
Now you're going in the circ.
Yeah, wire always have a tough time to.
No, this is run through. Yeah. That's the thing.
Well, once the wire which is behind the stent struts comes out, kind of loses its charm. Okay, good. So the question is, will the OCT go directly, or we have to open the strut a little bit?
No, we're not doing OCT. Let's go here. Oh, into the LAD?
Yeah.
Okay, let's see. Challenge the OCT.
Now you are going to do a pot first and then OCT, or?
Pot, yeah. We are doing a pot and then OCT, yes.
Would it be a
So the question,
dilate the ostium of the LED, crossover before you do the OCT? Would it be a wiser idea to do that?
Okay, that's what we are saying. We are going to challenge the OCT catheter. Would it go through the stent strut? Okay. So we done 408 at the left main. Okay, then now we do OCT into the LAD. You want to go here? No need, right?
Just here.
Little bit. Just to make sure the ostium is fully opened. Okay, good. Down.
10 atmosphere only.
OCT is ready?
Yep. Yes.
Key ready?
Yeah, ready.
Okay. So see to believe it.
I don't believe 2 wires. Do I take the, we need a kiss, right?
Yeah, you can take the circ wire out if need to be. Yeah, that's fine.
It's okay, leave it. Yep. They do multiple wires anyway.
Okay. Yeah.
Have a balloon ready, 3012 to open the stent strut if the OCT does not go.
Go.
358.
We have earlier balloon, but that was a long one. Yeah. Okay. So now we actually have the, you want to take the other wire out?
Which one?
Circ wire or
okay,
no?
that's leave it.
Leave it. Okay. 312 will be good.
In hindsight, would a 7 French guide have been a better idea in this case?
Recording in
Yeah,
progress.
yes. Very good point. So we actually had a 7 French sheath and 7 French guide. Only question was dampening. It was a lot of dampening, but yeah, then we
Recording
thought
stopped.
we'll do a one. That we do a one stent approach versus two. So definitely once you are two and you have 7 French, you should, the putting a 7 French guide is the right thing to do. Okay, OCT went in. Good.
Calibrating.
That's another wire could come out.
Yeah, it's a stent.
Okay, you're in the stent. I see you the stent, right?
Yes, right. So you can check.
Okay,
the
we are putting on the main screen.
Yeah, good flash. So yeah, you can.
Good flash.
A good flash.
Okay, ready?
Ready. Yeah, good image.
Disengage the guide a little bit.
I have.
Okay, let's study this OCT now.
Okay, first I'll do the co-registration.
We can make a OCT in the main screen. Make a OCT on the main screen, and they have.
Oh, hold on. Okay.
Confirm.
French. This is what was 7 French, many crush and out.
Yeah.
Okay, so first show. Okay, start from the mid LED stent. Yeah, looks open, expanded. Go to proximal. Yeah, expanded, still stent. And yeah, it's a proximal edge of the stent. Yeah, looks expanded, no malposition. I go to, this is the proximal part of the LED. Still proximal LED. And
that's a diag?
This is the circ.
Oh, that's a circ.
This
okay.
is a distal left main.
Okay, good.
Yeah, elliptical, but looks enough area.
Yeah. It's well opposed. Yeah.
Yeah. So this is almost the proximal edge of the stent, but no malposition, and it go to the catheter.
But tell us the ostial LED, right? That's the whole question is. What is the lumen in the ostial to proximal LED, right? Everybody agrees? That's our main focus at this time.
Right. So this is the ostial LED, like 3.2, a little bit elliptical shape. So yeah. So around.
Right there.
Yeah. Yeah, around 3 to 4. The areas.
Yeah, but how much? 3.75?
Here 3.75.
Yeah, 3.75 is close to 4 of the IVUS.
So I think question is, let's see the last picture. How does it look?
No, for this one we need nitro. Give a lot of vasodilators.
Actually, near to the ostium, it was 3.26 and it was nearly 3.3 only. It will become maximum 3.8. I don't know. And there is another disease in the just proximal to the stent also. In LED stent, you can see a small lesion. Actually, can you just show the lesion and what is the size of the lesion?
Yes. When on the angiogram?
Yeah, no.
No, on the OCT they want.
OCT, okay. Let's see. Yeah.
What is the area there?
Yeah, so.
Okay, that part.
A lot of plaque here.
Yeah,
the
still,
plaque
yeah.
and actually area is, I don't think it will maximum 3 will be there.
How much it is now?
This is the like 3. This is okay. The proximal part of the
proximal edge of the stent.
Yeah, almost proximal edge of the stent.
Okay, let's take a picture now.
What is the area? Lumen area, MLA of that part.
This is what we left.
It's 2.97.
The back say you don't want to do it. We'll come back.
The key is it's just about there, and this is the last picture. Can we show the last picture also? Go to epithenia. Get a verapamil.
It's 12 o'clock. We're done.
Good. Yeah, I know there are various ways to deal with the problem. This one could have been a mini crush also. That's one technique. No question on that.
I mean, angiographically looks good.
Yeah, angiographically doesn't look too bad, but doing a mini crush also, having 2 stent or DK crush, whatever anybody wants to do, that's okay too. Yeah.
So after doing an imaging, actually, we cannot tell that angiographically good. We have to have an image-guided angioplasty is the ideal way. And in this case, actually, there is a 2.8 is the distal proximal part of the stent edge of the LED stent. And you have a 3.26 or 3.3 is the ostial part of the LAD, ideally you have to put a stent. That is what I think.
Yeah, then we had to deal with the diagonal also, right? I mean, he said in this particular case, the diagonal, we need to take care of the diagonal also. If we put a stent there, we need to take care of the diagonal because otherwise going into the diagonal in the future will be tough. See that? So there is a diagonal disease about 60-70%. And the other question is that do we bring 2 stents and open the ostium of the LAD and do a mini crush at that level? And we actually have the 7 French sheath, we can put a 7 French guide. So that's one way. Second is, in this particular case, we have done quite a bit. This patient always will be willing to come back later on. At that time, after a few months, we can decide, let things heal, what we have done now. And that time, make an intervention of the LAD diagonal. So yes, remember we feel very good by putting more stents. Angiography looks very good, but many times we pay the price of that. So in this particular case, my strategy was exactly this, which is what we had done. That is single stent from left main to circ, rota and stent of the mid LAD. We have achieved that. And plus minus was the kissing balloon. Of course, the part of the ostial left main, yes, but plus minus of the kissing balloon of the distal of the LAD ostium in case it would have compromised. So taken all those things together, I would say that what our pre-procedure planning, and that is what we always emphasize. Let's have a pre-procedure planning, and we actually have fulfilled our all pre-procedure planning criteria. So I know that optimal, yeah, you can put 2 stents because then we'll require additional stent in the LAD and this stent in the diagonal. And so doing this little off the leak rather than putting a multiple stents at this time, let's pause. Patient is young person, come back again. Usually with this kind of left main situation, I bring them back within 3 to 4 months for angiographic follow-up. And at that time, touch up. As you mentioned, that LED lumen is still there. At that time, maybe decide based on the FFR. Don't go with the IVUS or OCT. FFR guided. If looks good the same way we are leaving now, moderate disease with negative FFR, do nothing. FFR positive, that time go ahead and take care of the LED diagonal.
So that we can do an FFR now also and tell that FFR is negative, then we will be very happy to see the result.
Yeah, that is true also. So if we do the LED FFR and if FFR is negative, everybody will be very comfortable. Yes. So what we'll do now, and I know that there is a time bound, we just finished our case. Exactly at 12 o'clock, what our time was, with a contrast of 140 cc's and fluoro time of 17 minutes, with air karma and DAP, which we calculate in everybody, air karma of 1.3 and DAP of 75. So remain within our limits, but we'll do FFR. I think it's a very good point, but I would just not stop your progress of the conference because you are waiting for a half hour that lecture by Dr. Greg Stone, which we really worked very hard for you to get benefit of his tremendous knowledge of the literature of particularly the new durable polymer drug-eluting stents, Zion's variety, that how safe and durable they are. With that note, we stop here. But yes, we'll now LED will do it with the FFR.
Sir, Dr. Greg Stone hasn't joined. Dr. Greg Stone.
Sir, at the outset, we should tell that it is an excellent, wonderful demonstration of a severely calcified osteoproximal circumflex where there was a stent was creating all the problem. It was a wonderful demonstration, sir. Thank you.
Sir, can I ask one question, sir? In case if you consider a stenting of LAD now from the ostium, what technique you will go for? It is like tap technique or reverse mini crush or something? What will be your?
No, it's will be tap. Will be tap now. Okay. We'll do tap. Yes. So it's a 90-degree turn, and we do very good with the tap.
Okay.
Samim sir, we'll continue with you. Sir, we'll continue with you. Dr. Greg Stone hasn't joined it. So we'll continue with you. Once he joins, we'll go for his lecture and get back to you.
Okay, no, fine. So we can do FFR. Let's get the FFR, please. Yeah, we are going to do FFR now.
Dr. Bhai, you see here, excellent case. In fact, I was very impressed by the fact that you have rotated across the ostial LAD to go into the proximal LAD, but still the OCT did not show any major issues with the proximal and ostial LAD. So I think it's a very good idea not to complicate the issues, check the FFR. If the FFR is good, come out of the case. It's an excellent idea.
Pratap, what is your prediction of the FFR in this case?
think it will be positive.
FFR
I
will
think
be
I
negative.
always like the prediction also. My prediction is will be negative. Let's see.
Or actually, I want a negative. I want an vote against. Otherwise, there is no use of doing an FFR. Sir. If you think it is positive, a negative, I think it is positive. Then only that FFR doing will be useful.
We're doing a non-adenosine types.
No. I think we do FFR. I mean, yeah, we do a IFR and so, but to me, real data and most of them are with the FFR. I'll go with the FFR.
Okay.
FFR
Particularly
will
with
be negative
the
in this
yeah.
case. It will be negative in this case. And if you don't
You
want to
think
do
so?
a stenting, I think FFR will be the best choice.
You think will be negative? I'm surprised. I surprised a lot of people thinking negative. I think it could very well be positive.
I am telling it is positive, and not everybody. There are few people thinking it is positive also, sir.
I also believe it will be positive.
This will be 0.84.
It's a proximal LED, so large area, so its likelihood of being positive is high.
By VC, what is your prediction?
You're mute, sir.
And 0.84 is my number.
My
And
God.
I'll normalize into the circ. Yeah.
Sir, by the time you get the FFR wire ready, just a small query on your rotablation technique. You showed us that you do low speed rotablation. What is your reasoning for that? And when the burr doesn't cross the lesion, would you still continue with low pressure, low speed pecking, or would you go at very high run speeds, rota speeds?
Very good point. So there is one randomized trial from Japan, which was negative in terms of whether you use a low speed, 150 or use 180 to 200 in terms of CK release and slow flow, no difference. What we started teaching this slow speed back in 2002, 2004, we found it caused less perforation and less chest pain to the patient. So that's the only advantage. Now, if you're done 4 or 5 times, 150,000 does not cross the lesion, then you definitely go up to 170, 180, particularly if the burr is less than 2 millimeter. Okay, with that note, we are ready for equalize. Okay, guys, put a IVUS on the screen, the FFR on the screen now. Take the IVUS out. IVUS is, yeah. Equalize? No, but we need to see that on the screen. Why we are not seeing it? Hemodynamics. Show the hemodynamics, please. Good. Okay. So we are ready. We may have to put a buddy wire, look for other wire side by side, because remember these wires are not that user friendly. So we may have to put wire first. Good. Okay, went in. Okay. All right, resting is 0.90. Whoa. Start the drug.
You cannot see it.
One, you can see it on the top corner. 0.87 is the resting. The Senate.
Sir, a good point that you
Fluorescent, okay.
disengage the guide catheter.
Yeah, that's right. Very important in this case because there is some, my left main was there originally. And usually we do it for 2 minutes. But anything, if you started your resting less than 0.9, my prediction has been it's always positive. So we are now to about 45 seconds and we're still stuck at 0.88.
We'll be happy if FFR is non-ischemic so that you can avoid multiple
Believe me,
stents.
I will be happy to. So everybody, yeah, key is, I said again, many times, looks us angiographically, we put a stent, artery looks completely fine. Patient comes back. We are in trouble. Nope, positive. Okay, stop it. Stop it. Okay. So FFR is 0.7, very quickly positive.
You want to do a pullback and see?
Yeah. Yeah, we can do pullback now. Yep. No, but key is that it's I'm sure the gradient will be just in that our proximal area once you start getting it here. And what happened? Greg Stone can never logged in yet?
Not it.
I hope he remembered that. Although it's a 0.91. Yeah. So question, let's engage again. And that's fine. We have 2 wires. Yeah. Okay. Good. Let's get 2 new wires.
Sir, Samim sir,
Okay.
can somebody from your team contact Dr. Greg Stone? Is he joining us now?
They're trying apparently.
Yes, sir. Thank you.
Yeah. So now, always say, once you have that information, you have to react to it. So in this particular case, I think what we do is very simple. We do a technique for that LED. We are going to put one wire into the circ, hopefully, and you do whatever balloon was there, proximal.
And diagonal, you're doing a provisional strategy for the diagonal.
Yeah, right now, I think with this all complexity, I'll wait for the diagonal.
Exactly.
And also tell that only LED and diagonal.
Yeah, exactly. Yeah, right. Right now, since we are doing, in this case, I would just avoid the diagonal, try maybe medical therapy for the diagonal, and goal now is do the LED because very ischemic, and this point of doing the FFR, I mean, my goal was to delay it, but I think it's approach that particularly we have done such a good work. We don't want this patient to remain sick. And this
better is better than the best, sir.
Yeah. Good. Okay, we take a 3-0, 28, right? Yeah, no, the stent, I'm saying. 3-0, 28 or 23, 1 second. No, 23 will be okay. Yeah, 23. Good. Okay, let's go. We dilate the ostium first. Yeah. Go up. Good, negative. Go up again. 16, 18, 20. Negative. Go up. Yeah. 20.
The 3-0 balloon?
Negative. Yeah, this 3-0.
The circ wire?
This is actually, yeah, we are going to put a sharp wire now. Yeah, absolutely. Go up. 20. This is within that LED stand. Good. Okay, let's see it again. Go up here. Negative. Always deflated in these complex cases. Move your deflated balloon, so make sure the room is clear cut for your stent. You don't want a difficulty there. Go up. What length this is?
This is a 12.
12. Oh, then we can take why don't you give me 3.5, 18 Zymes? Yeah, negative. Right? I mean, this is a 12, 18 will be good, and it's a 3.5 millimeter vessel because it was 3.3 or 3.4 before. Good. Another wire for work. Yeah. That's good. So clearly that we're wiring now and ready for the stent, and then we use a 3.0 or 3.5 balloon for the ostial circ. Yeah, stent. Open the stent, please. So we're going with the same Giant's Sky Point. I hope soon this new generation will be available in India. There's still a lot of issues that what stents are available and so. Okay.
Sir, is there any point in undersizing the stent in the proximal LED rather than going with a 3.5, just to go with a 3 mm stent, hoping that the diagonal doesn't close down, and before post dilatation just to rewire the diagonal so that in case while post dilatation with a 3.5 millimeter balloon closes down the side branch, you're in a better position to save it?
I would say that if I would not have done the OCT as mentioned earlier, you react to what you have, and in this particular case, get that 3.0 balloon, other balloon. So now we need a balloon for the circ. Yeah, so that's a completely good approach also. There's no question there. So you need to post dilate. So this is okay, go connect and go negative. So, yeah. So what we are going to do now, we have the balloon and the LED, I mean left main to circ for our tap. And yeah, that use a smaller one, 3.5 or 3.0, and then post dilate, good approach also. But we also saw the lumen was on the OCT, it was almost 3.4. And so this is, I think it's reasonable to go with the 3.5. And the lumen itself was 2.3. That's okay, why? Yeah, always when you advance your other stent or balloon distally, not leave it at the bifurcation level because that will create a more problem. But the 6 branch, the crisscross is very common. See this happen. Give me a 3.512 new balloon, particularly using a old balloon. And 6 French is the trouble. I mean, again, the strategy wise was different. We were able to do what our strategy was, but clearly when you present these cases, and it's always good to have input from the panelists. And so we could have done it, but then the point which was made that let's do the FFR, which was good, made the point, and that's where we are now to put a tap stent in the ostial proximal LED. Okay, now going back again, hopefully this one will be a little easier. Wire crisscrossing is happening too much. Yeah, that's always the issue with the 6 French. Yeah, so what I'm going to do is rather than make it complicated, we are going to deploy, and then we can do, because knowing that this we know exactly will be a tap point of view. One second, please. Okay, just a little die now.
Yes, true.
Yeah. Not at 1 second. Good. Go up. 12. So we are going to deploy at low pressure. Negative. Go up again. Negative. And always overlap stent. Just go few atmosphere. Go. 10, 12. Negative.
So it's also a great message to the youngsters, wherein a lot of people are into radial intervention, would try to go with a 6 French guide catheter through the radial approach. So even a seasoned operator like you can face challenges with a 6 French guide catheter while doing a left main bifurcation intervention.
Yep, that definitely. Okay. So far good. Now we have to just finish our kissing. So now we are going to go to the circ first. Yeah. Definitely ostial LAD, proximal LAD looking quite good. And now
you could.
This is the 3.5 for the circ and go with the LAD. I think this is the wire crisscrossing is the issue here. So clear, we take back the LED wire, where the circ wire there.
Yes, possibly stent struts of the LED stent preventing.
No, right now we're actually not even going to the LED yet. See that? Okay, so we come back. Yeah. So what I'm going to do is, so this is good. So just want to make sure this goes into the LED without any problem. So now we are going to wire the LED wire. I'm going to put in the circ now.
Hello, everyone. It's good to see everybody.
Okay, now good. So we got Dr. Greg Stone. So let him give the lecture and we'll just finish the case on our side. But we are done now. We're just going to do a kissing balloon here. All right, guys.
So shall we get back to you after the lecture by Dr. Greg Stone?
Yeah, that is fine. Yeah, we can just show that because we will be doing other case in this particular room, but I can send the video picture of this case. Yes. Good. Okay, start the lecture. Yeah.
Yeah. Thank you so much, sir. Natarajan, sir, would you like to invite Dr. Greg Stone for his lecture?
On behalf of the Scientific Committee of Conquering Coronaries 2.0, let me invite Professor Greg Stone to give his lecture. The much awaited last session of the day. We look forward to your presentation and thank you for accepting our invitation. Over to you, Professor Greg Stone.
Well, thank you very much. It's good to see everybody. I'm glad this is working. I'm actually in a car. This was the only time we could work this out, but it looks like it's going to be perfect. And I'm sorry we had some technical issues connecting. So let me share my screen and then I will, here we go. So you should be able to see my screen now and I will go to full screen mode. So what I'd like to do over the next 20 minutes or so is to talk about stent design, polymers, and clinical trials, and what we've learned about how basically stent design matters and the outcomes of where we are with metallic drug.
Give us compliant.
Okay. So if possible, maybe we could stop the audio coming from the cath lab. That would be great. So I'm going to take us on a historical view and go all the way back 45 years ago to Andres Grunzig's first balloon angioplasty. And you all remember this. And when he did balloon angioplasty and when it worked, it was just a remarkable thing from the first case here in Zurich in September 16, 1977. But acute closure was the so-called Achilles heel of angioplasty. Because angioplasty works by creating dissections, it would often tear the vessel wall. That plus thrombus would lead to acute closure in up to 1 in 10 cases necessitating emergency surgery, and many of those patients died. And that led to the development of bare metal stents. And these were the first two stents. Many of you were too young to even remember these. But the Johnson & Johnson Palmas shot stent and the Cook GR2, I mean, look at these stents. They look so crude, and you can't even imagine that these things worked. But they did, and they really were the solution to acute closure. But the problem with bare metal stents was restenosis. And because bare metal stents actually caused more medial injury than even balloon angioplasty, you would often get a lot of tissue proliferation, and 20 to 50% of patients after bare metal stents got balloon angioplasty. So for that reason, drug-eluting stents were developed. And the first generation of drug-eluting stents were Cypher and Taxus. And I was privileged to lead the taxes program and introduce that to the United States. And here we had relatively thick stainless steel stents with durable polymers that were eluting both paclitaxel and sirolimus, respectively. And again, the stents were thick strut. These were rigid devices. The polymers were not particularly biocompatible, but the polymers were necessary to control the dose and the release kinetics of the drug. And when these things worked, they were remarkable. And you all know drug-eluting stents, and they would basically take the acute results of angioplasty and then freeze them for 7-10 years, the life of the patient. And we reported this very transparently. For example, the pooled individual patient data from all of the randomized taxis trials, you could see about a 50% reduction in target lesion revascularization. They weren't perfect. They didn't eliminate restenosis, especially in complex lesions, but they improved things by 50%. But the Achilles heel of first generation drug-eluting stents was very late, that is greater than 1 year, drug-eluting stent thrombosis. And you would have a case like this, a mid-circ lesion with a perfect result, and then the patient would be doing absolutely fine until about 3.5 years, and you get sudden thrombotic occlusion of the circumflex. And we learned that this, as we reported transparently, was not occurring within the first year, but did occur after the first year. And both with Cypher and Taxis, we found increased rates of late myocardial infarction because of late drug-eluting stent thrombosis. We found there were lots of reasons for this. Number one, the stent struts would not completely endothelialize. About 40% of the stent struts would stay endothelialized. We often also had hypersensitivity and inflammatory reactions to the polymers that were used, and the polymers could create vascular toxicity. So you would have actually late positive remodeling because the vessel wall was so inflamed, and all of this would cause late malapposition, and it would have abnormal vasomotion, and all of this would contribute to late stent thrombosis. So this led to the development of better drug-eluting stents, the so-called second generation drug-eluting stents. We shifted to sirolimus analogs as the drug because it had a better toxic therapeutic ratio. But more important was the use of really biocompatible polymers that were very elastomeric, that is, they were stretchy, and we used thinner stent struts that were more malleable, made out of either cobalt chromium or platinum chromium. And I then led the Xience series of SPIRIT trials, and we did a series of 4 different SPIRIT trials. We pulled them in a patient-level database, and we showed compared to Taxis that overall major adverse cardiac events were reduced by about 34% compared to Taxis, and it was both more efficacy, so you could see ischemic target lesion revascularization was reduced, and it was greater safety. And that was the biggest difference. You could see about a 70% reduction in stent thrombosis, particularly early stent thrombosis within the first month, but also very late stent thrombosis. So these were much, much better devices. So now it's 2021. Why do we need even better stents? Well, first of all, we haven't eliminated restenosis and stent thrombosis yet. We would like to do that. Second, we want to reduce dependency on long-term dual antiplatelet therapy, which became the norm in the United States and elsewhere to try to reduce very late events. And third, we want to improve the lifelong prognosis after drug-eluting stents. So what do I mean about that? It's very interesting that stents, we used to think if they don't restenose by 1 year, problem solved. But that's really not the case. We did this very detailed analysis of 17 randomized trials, 22,000 patients, where we looked at the 5-year outcomes from randomized stent trials, bare metal stents, first generation and second generation. And you can see within the first year, looking at target lesion related events, as you go from bare metal to first generation to second generation, the outcomes are getting better and better. But if you look from 1 year to 5 years, the first thing you see is that target lesion related events, these are events arising from the stent, principally target vessel MI and target lesion revascularization, continue to accrue at a very steady rate from 1 year to 5 years. And there's really not much of a difference between the 3 stent types. It's about a 2% per year event rate after every 1 year, after year 1. And pretty much every study has shown that. So for example, if you look at the ICER Test 5 trial, they reported 10-year follow-up. This was 3,000 patients randomized to two different drug-eluting stents, a sirolimus-eluting and a propofol-eluting stent. And here you can see the event rates early on, and then after 1 year to 10 years, you can see this linear increase, about 3% per year after year 1. So an ongoing risk of events occur and arise from drug-eluting stents that are still principally late restenosis, but also late stent thrombosis. So how can we further improve metallic drug-eluting stent outcomes? Well, we can either make the stent struts thinner, we could use bioabsorbable polymers. If the polymer is really the problem, let's try to get rid of the polymer after a certain amount of time, or we can eliminate the polymer altogether. And as we've watched over the last 10 years or so, this slide kind of summarizes the evolution of metallic drug-eluting stents. First, you can see we've gone from paclitaxel and sirolimus to now almost all sirolimus analogs, everolimus, zotolimus, etc. When we look at the polymer and the metal and the thickness, again, we started with stainless steel and we moved to more malleable polymers, and the thickness of the polymers themselves have gotten, we started with durable polymers, that's the green, and then we moved to biodegradable polymers. And you can see that the thickness of the polymers themselves were quite thick at the beginning, and some of them have gotten very, very thin, less than 4 or 3 microns. And when we go look at the stent itself, we've gone from stainless steel for the most part in gray to either cobalt or platinum chromium, which again are much more malleable and can be made thinner. And you can see we've gone from 130 to 140 microns to as small as 60 microns or so with the newer design. So we're getting thinner, we're using biodegradable polymers. So let's ask ourselves, from all the clinical trials that have been done, and there have been lots and lots of clinical trials in the drug-eluting stent field, are the outcomes improved with ultra-thin drug-eluting stents? So ultra-thin drug-eluting stents, even thinner than contemporary 80 to 100 micron stents, have less side branch coverage, so that can lead to fewer peri-procedural MIs, and they cause less turbulence and more rapid endothelialization because they're so thin. That can lead to reduced stent thrombosis and restenosis. So altogether, there have been 16 randomized trials with 21,000 patients looking at the so-called ultra-thin strut stents, less than 65 microns, versus the second generation drug-eluting stents of 81 to 120 microns. And the 4 ultra-thin drug-eluting stents in these randomized trials were our Cyro, the MyStent, the BioMime, and the Superflex. And here is, in this study, and this is a meta-analysis that I was the senior author on, that we recently published. Target lesion failure was the primary endpoint, and here you can see all the results. The overall relative risk was about 0.15 reduced. That's a 15% reduction in target lesion failure at a mean 2.5-year weighted follow-up. And you can see this was statistically significant with a p-value of 0.006. The I-squared value, which is a test of heterogeneity between these different studies, shows mild to moderate heterogeneity. So there are some differences between the studies. But overall, there's a modest 15% reduction in target lesion failure by making the struts thinner. So why is that? Well, here's all the data. And you can see here, target lesion failure is reduced by 15%. Target vessel failure is reduced. No overall differences in death or myocardial infarction. The real difference was that clinically driven TVR and TLR were somewhat reduced. So that's really the benefit of getting thinner and thinner. The stent thrombosis rates are so low with all our stents that while there was a little trend to reduce stent thrombosis by making the stent struts thinner, it wasn't a significant difference, but we could see somewhat lower rates of target lesion and target vessel revascularization. Now, on the other hand, I do want to show you here, there were actually some slight trends in the opposite direction for death to be increased. It was not statistically significant, but it was a very consistent finding in the studies. And it was both cardiac death and non-cardiac death. And here I broke down all the results within the first year or after the first year. So this was not statistically significant, but again, there was a borderline increase, and we don't know that that's real or not, but the editorialist and others were concerned about this, and we really still need more data to know if there's not some reason why getting too thin may actually be deleterious. But all the other cardiac outcomes are going in the right direction. Now, what about using bioabsorbable polymers as opposed to durable polymers? So the concept of a bioabsorbable polymer-based drug-eluting stent is that the bare metal stent remains after polymer resorption. So there could be fewer late and very late stent thrombosis events and possibly less restenosis. And we know that the polymer is not necessarily a good thing. The polymers themselves can be dislodged as you're passing down a fibrocalcific vessel. So you could leave these very irregular oniduses for thrombus after you place the drug-eluting stent at the site of the lesion. In addition, as I mentioned, particularly with the earlier polymers, you can get both giant cell and eosinophilic infiltration and other inflammatory reactions that can lead to inflammation, positive remodeling, late malapposition, and stent thrombosis. So for this reason, maybe we should reduce the polymer after, or eliminate the polymer after it's done its job of controlling and delivering the drug to the site of the lesion. So we performed a meta-analysis of 89 randomized trials with 85,000 patients of bare metal stents versus durable polymer stents such as Taxus, Cypher, Xience, Resolute, Endeavor versus bioabsorbable polymer stents. And in this study, what we saw was that there was the bioabsorbable polymer stents maybe were a little bit better than bare metal stents and first generation Taxus stents, but there was no significant differences between bioabsorbable polymer stents and durable second generation biopolymer drug-eluting stents. Perhaps this was best seen by a real detailed and important test of the Synergy stent. And this has really been held out as one of the best bioabsorbable polymer-based stent. It's a thin strut platinum chromium platform. It's 74 microns, so it's flexible and conformable. It elutes everolimus from a very thin layer of PLGA, only 4 microns thick, and it's only on the abluminal side. That is the side that's exposed to the lesion. And the everolimus has gone within 3 months, and the polymer itself has gone within 4 months. So it's one of the fastest eluting polymers. So this was tested in the Involve 2 trial, a 1,684 patient randomized trial of Synergy versus Promus Element, which is very similar to Xience and Promus. And the overall primary endpoint was target lesion failure at 1 year. Here's the primary endpoint at 1 year, and here it is at 5 years. So absolutely no difference whatsoever between the bioabsorbable polymer stent and a really good durable polymer stent. And when you look at stent thrombosis, the stent thrombosis rates were also identical. So bioabsorbable polymers really are not worse than durable polymers, but the good durable polymers are equally as good as bioabsorbable polymers. So what about polymer-free drug-eluting stents? The concept here is that once the drug's eluted, a bare metal stent's left behind. So this, by not having the polymer, you don't have all those clumping and dislodgement issues. That might lead to more uniform drug delivery with no adverse polymer reactions, not even for a week. And then might promote more rapid healing and shorter mandatory duration of DAPT because it's really a bare metal stent. On the other hand, it can be very difficult to control the drug dose and the elution rate without a polymer. And in fact, some polymers, like the fluoropolymers on Xience, are actually thromboresistant and may even promote healing. So the first polymer-free drug-eluting or drug-coated stent, as it's called, that got a lot of attention was the BioFreedom drug-coated stent. And this was actually a 120 micron stainless steel device, so relatively thick stainless steel, in which the abluminal surface was micro-etched. Okay, basically it was roughened to create all these nooks and crannies, and they coated this inside with biolimus, which is an extremely lipophilic limus analog. And the reason the lipophilicity is important is because if it's hard to get the drug to the lesion, at least whatever gets there, you want it to really be held within the lesion. And if it's lipophilic, it's going to have high retention characteristics in the vessel wall. So this was tested in the Leaders free randomized trial. And this was the first trial that said, let's see if we can only do 1 month of DAPT in patients at high bleeding risk. And let's see if this drug-coated stent acts like a drug-eluting stent and if it's as safe as a bare metal stent and more effective. So they randomized over 2,400 high bleeding risk patients to either the BioFreedom drug-coated stent with Biolimus versus a similar bare metal stent. And all the patients had 1 month of dual antiplatelet therapy. And their primary efficacy endpoint was clinically driven target lesion revascularization. And sure enough, there was about a 50% reduction in TLR. So this did act like a drug-eluting stent. And when we looked at safety, there was no difference in cardiac death. And in fact, myocardial infarction rates were even somewhat lower with the drug-coated stent, maybe in part because of less restenosis, with no difference in stent thrombosis, although it is worth pointing out that the stent thrombosis rates with both of these devices were relatively high at about 2%. So this led to the sort out group to say, wow, that looks like a pretty good stent, but it's thick. It's 120 micron stainless steel. So let's compare it in a very big trial to a really contemporary drug-eluting stent, the Orsiro, 60 micron cobalt chromium, PLLA-based biodegradable polymer releasing sirolimus, and a 3,150 patient all-comers trial. But because it was all comers, they used 6 months of DAPT in stable CAD and 12 months of DAPT in ACS. And what did they find? They found actually that the target lesion failure rate was somewhat higher with BioFreedom compared to Orsiro. So actually non-inferiority was not met. Why? Cardiac death rates and target lesion myocardial infarction rates were similar, but it was not as effective an anti-restenotic device. So BioFreedom had a 3.5% TLR rate, whereas Orsiro had a 1.3% TLR rate. And that's what you get with going from 120 microns to 60 microns. There was no difference, though, in stent thrombosis, but again, all these patients did get extended DAPT. So with this in mind, now the question is there anything special about these devices, or can all good contemporary drug-eluting stents really be treated with only 1 month or 3 months of DAPT in high bleeding risk patients? And this is a really hot topic right now. And there have been about a dozen different studies looking at short DAPT regimens, high bleeding risk patients. And here you can see a list of the most important studies. A lot of these are registries, but some of them are important randomized trials. One randomized trial that we ran was the Onyx 1 randomized trial, which looked at BioFreedom, and we compared it to the Resolute Onyx drug-eluting stent, a very good contemporary DES, in nearly 2,000 high bleeding risk patients. And all the patients got 1 month of dual antiplatelet therapy. We had a primary safety endpoint of cardiac death, MI, or stent thrombosis, and you can see there was no difference overall in safety between these two devices. So Onyx was very safe with 1 month of DAPT. There was also no significant difference in target lesion failure, cardiac death, TVMI, cardiac-driven TLR, or stent thrombosis. So everything basically was very similar in this 2,000 patient all-comers high bleeding risk trial with 1 month of DAPT. The STOP-DAPT 2 trial was a 3,000 patient randomized trial that was actually a little more interesting. Here it was looking at 1 month versus 12 months of DAPT in basically an all-comers population, saying that maybe we just don't even need extended DAPT anymore. And this study was run in Japan, and you can see their primary endpoint was a net adverse clinical event endpoint consisting of both the ischemic endpoints and major bleeding endpoints. And in fact, with Xience, in this all-comer population, the 1 month DAPT group did actually better than the 12-month DAPT group. So why was that? That was because major bleeding was significantly decreased by going in this all-comers population from 1 year of DAPT to 1 month of DAPT, and there was no difference whatsoever in the 1 year MACE rate. So 1 month of DAPT in this population was safe, and clearly reduced major bleeding. But I will point out how low these event rates are. And again, these were relatively non-complex patients, even though it was an all-comers patient population. You could see most of the patients just got one stent, and they used IVUS or OCT in 98% of their patients. So finally, I'm going to ask you now, what is the role of bare metal stents in the contemporary drug-eluting stent era? And I would pose to you that the answer is there is none. So believe it or not, there have been 20 randomized trials and 26,000 patients of looking at newer generation drug-eluting stents. That's basically all the DES we use, except for Cypher and Taxus, compared to bare metal stents. 20 randomized trials. And if you look at this meta-analysis, a patient-level meta-analysis, with the primary endpoint being cardiac death or myocardial infarction, cardiac death or MI is less with drug-eluting stents than bare metal stents. That is, again, in these all-comer studies, they were safer to use drug-eluting stents than bare metal stents. And if you look at it, definite stent thrombosis was reduced by 36% with drug-eluting stents compared to bare metal stents, and target vessel revascularization was significantly reduced as well. So compared to bare metal stents, contemporary drug are not only more effective, but are also safer. So if I was going to conclude with where we are with stent technology in 2021, I'd say that drug-eluting stents have gotten really good. Bare metal stents have no further role. Take them off the shelf. But drug-eluting stents are not perfect. Iterative improvements are being made in stent configuration and delivery system construction, but really it's difficult to markedly further improve outcomes with metallic drug-eluting stents. The polymers are good, the delivery systems are good, they're very, very good. I do believe that major outcomes can be substantially improved by better technique, particularly use of intravascular imaging, physiologic guidance to select the right lesions, lesion preparation strategies for heavily fibrocalcific lesions, and optimal use of pharmacology. That's really where we need to focus. And finally, future major clinical advances are going to require breakthrough technology. I didn't talk today about bioresorbable scaffolds. I think you know that story. They're still being developed, and we're getting a next generation series of scaffolds that are going to be very thin, and hopefully we'll see that that might be the solution to the 5 and 10 year ongoing risk of events that metallic drug-eluting stents still pose. So thank you very much for giving me the opportunity to present this lecture to you.
Thank you, Professor Greg Stone, for that wonderful lecture. You took us through the evolution of drug-eluting stents in terms of thickness of the struts and in terms of the polymer, so from durable polymer to biodegradable polymer to no polymer, and for that excellent concluding message. It's indeed a privilege to have you meeting. And any questions from the fellow panelists?
Yeah, Natarajan. Greg Stone's lecture was damn good. The one question we come across frequently is about the last slide. In current scenario, no rule for bare metal stent. But in the pre-transplant group, for example, someone is going for a liver transplant, the transplant teams, when the patient needs a revascularization before that, would insist on a bare metal stent, despite we telling that bare metal stents do not have a role, and the current generation, there are enough good tests with HBR safe short DAPT modalities. What do you say, Greg, in such scenario? Pre-transplant, revascularization, going for a liver transplant in 3 months, or say 1 month.
Yeah, I would use a contemporary, good drug-eluting stent, on a thinner strut stent, and 1 month of DAPT. If the transplant's going to be in 1 month, I'd prefer to wait 3 months. Any stent, whether bare metal or drug-eluting, will have a slightly higher rate of stent thrombosis in the perioperative period if it's really early. So if possible, I would wait 3 months, but if not possible, wait 1 month. But in either scenario, I would use a drug-eluting stent.
Professor Greg Stone, with that extraordinary data on low duration dual antiplatelet therapy, making not much of a difference in comparison to longer duration of DAPT in high bleeding risk patients, is it okay to say that in any patient, even without a high bleeding risk, we don't have to give prolonged DAPT. What's your comment on that?
I think that is probably true. I would be certainly very comfortable with 3 months of DAPT in stable CAD and 6 months of DAPT in ACS. One of the benefits of long-term DAPT is not necessarily at the stent site, but it's at other sites in the coronary artery, the unstented sites. And in acute coronary syndromes, where there's more vulnerable plaques and thin cap fibroatheromas, I do think there is a role for longer-term DAPT, for at least a year, probably in low bleeding risk patients, to try to prevent non-stent related events. But I do think that if there's any concerns about bleeding, then short DAPT really seems like it's fine. There's one more very big trial that's going to come out, that will come out later this year, called the Master DAPT trial. And that's an important trial because that was 1 month versus 12 months of DAPT in 4,000 randomized all-comers patients. And they're going to have many more complex patients than was in the Stop DAPT 2 trial from Japan. So that is probably going to be a major trial. That was with Ultimaster, and that's going to be a major trial which may change the guidelines for DAPT duration.
What is your prediction of the result of that particular trial? As a future prediction.
I actually am aware of the results of the trial, so I can't make any predictions.
Actually, Greg, what do you think about LMC and small vessel stenting? What is to be the predicted DAPT duration?
So small vessels certainly are a risk factor for both restenosis and for stent thrombosis. So that might be a situation where you consider a little bit longer DAPT duration, especially if you put in multiple or very long stents.
LMCA? Left main?
Oh, left main does not concern me. Left main, on the other hand, is a short lesion in a very large vessel, and the stent thrombosis rates in the left main coronary artery have been very, very low. If you have a complex bifurcation or trifurcation where you put 2 or 3 stents in the left main, then I would be cautious and go for 6 or 12 months of DAPT. But for most left mains, I would be fine with 3 months of DAPT.
Dr. Stone, regarding the resurgence of resorbable scaffolds, what is your prediction?
Well, it's difficult to predict. I actually think that they may be very, very important. And when we reported the long-term outcomes of the Absorb program from pooling all of the Absorb data, within the first 3 years, we saw an increased risk of events compared to Xience. But then after 3 years, once the PLLA is completely resorbed, we saw a similar or lower rate of long-term events compared to Xience. So the purpose of bioresorbable scaffolds was always to improve long-term outcomes. But that first generation, of course, was not thin enough. It didn't have optimal expansion characteristics. And, Abbott, who was the leader in the field, has brought back a 99 micron device, which is being used successfully right now in the periphery. I'm hoping that will come back to the coronaries. There are other companies, such as Elixir and others, and several companies in China that have thin strut bioresorbable scaffolds. But they're going to need large development programs. They probably need to be put in with intravascular imaging to really ensure optimal implantation. And they'll just need large randomized trials to make sure that they're as safe early as contemporary metallic DES. If so, then I'm very favorable for their very long-term outcomes. But they are going to have an uphill climb.
Great. One quick question. The spectrum of coronary disease, primary PCI with the thrombus rich and soft bed, and then the chronic calcific hard bed scenario. Is there a choice in the test you would choose? It's a very provocative question, I know that.
Is there a choice for which stent I would choose?
For which side, for the extremes of these cases, the same stent cannot be good in both the scenarios. What is your take?
I've got to tell you right now, I don't think there are major differences between the different drug-eluting stents. I've shown you data from hundreds of randomized trials and hundreds of thousands of patients. And the best data is that the thinner strut devices may have a slightly lower restenosis rate. I don't think there's a meaningful difference in stent thrombosis. I still like, personally, I like the fluoropolymer coated devices when there's a higher stent thrombosis risk, because the fluoropolymer definitely does have an antithrombotic property. So in many of the MIs, I still personally use fluoropolymer coated devices, but there's no big randomized trials to suggest that they're safer in those settings. So I really think it's, you need to know the stents that you're very comfortable with, that are highly deliverable, and I think most of them are really very good right now in most scenarios.
Thank you.
So can we move on to the cath lab? Dr. Sharma is ready there with the final results.
Yeah, I'd love to see
Thank
how
you,
he's doing.
Greg Stone, for that wonderful lecture once again. Thank you very much.
Thank you. I enjoyed
Always
very
masterful lecture.
Thank you, Samin. And masterful.
Beautiful.
Let me see your final result.
Yeah. So basically, if we can show that, so remember that's where we decided, did the FFR, and FFR was positive of the LED. So we went, opened the strut, and then put a 3.518. And remember what happened? You try to put a balloon, the difficult wire entangling. We rewired it, so that's okay. It's a 90-degree turn. You will just bring the stent and the ostium with a tap technique, and then of course you bring 1 millimeter back, go to high pressure, and then rewire. That's what we did. And then go with your 2 balloons. Excellent 3.5 and 3.0, and this is the final result. And patient actually, we did not do the last IVUS, although looked very good. As you can see here, proximal LED diagonal remained fine. Patient got quite restless because lying on the table for almost 2 to 3 hours, which is not uncommon. But no changes, no chest pain, no EKG changes, and that's where we ended. So now this patient doesn't need to come back for the stage of the LED. And I'm sure the diagonal we can very well manage with some beta blockers and so.
Wonderful. Wonderful result.
Thank you.
Beautiful.
And I just wanted to say the point which you said is we get the same trouble. Anybody wants to go for renal transplant, liver transplant, they want us to do a BMS even in Mount Sinai.
Yeah.
And we say that, guys, because guidelines have not changed. I said these stents 1 to 3 months, preferably 3 months good, if maybe necessary 1 month, and bare metal we don't have even carry.
Right.
So this is a big, we are having this same question what having in India, even at Mount Sinai, that all these, our transplant surgeons who are very urgently need to be done, they want a bare metal. So we write notes after notes, document 5 phone calls, and he says, these are better. All our DES have shown now better than BMS, even in the short-term stent thrombosis. But key is that this question comes up every other day, every other week, I would say, even at Mount Sinai.
All the time.
All the time. All right, guys, good luck. I think reaching your night time, fantastic.
Thank you, everyone.
Thank you.
Thank you. Thank you, everyone. Let me take this opportunity to thank each and everyone, all the panelists, the speakers, as well as the moderators for being with us today. Hope to see you all tomorrow, 6:30 in the evening. Thank you so much.
Good night.